Welcome, everybody, to the International Myeloma Foundation's Regional Community Workshop. We are obviously virtual here, and it's a pleasure to be with you tonight with a wonderful lineup of speakers. We're going to learn a lot and listen to your questions. And before we get started, I just want to share with you a few things here. We always want to hear from you. And so this feedback that we are kindly asking you to complete, you will, at the close of the meeting, you'll get this little feedback survey is going to pop up for you. And it's also going to be emailed to you shortly after the workshop. And we ask you to please just take a moment. You'll see this little box here that says continue, and we would love to hear from you how we can continue to bring you quality programs with the information you need. And it is my pleasure to thank our sponsors for this evening, and they are AbbVie and Amgen and Bristol Myers Squibb, GSK, Johnson & Johnson, Karyopharm, Sanofi, and Takeda. This is our agenda for tonight. You've probably already seen this, but to give you an idea so you can plan to get up and stretch when those breaks are going to be happening, and you can see it's going to be a progression. We'll take you through Myeloma 101 with Dr. Joe McHale. And then we have Kim Noonan, who is going to talk to you more about understanding side effect management and shared decision-making and being in charge, taking the reins. And then we have Dr. Wiesel, who will be talking about frontline therapy. We will have a Q&A, and we'll talk next about how do you submit your questions. And you could see then we'll have a break. Everybody can get stretched and maybe a refreshment. I hope you have a glass of water next to your side already. And you can see the rest of our schedule right there. And I just want to give you a nice quick reminder that we have the IMF's info line available to you by phone and by email. You can see those contacts there. And this is Paul Hewitt, Missy Kleptar, and Teresa Michelli, and they are there for you to talk about all sorts of myeloma resources and questions. So please feel free to reach out to them, not just today, but anytime. I should say Monday through Friday Pacific time. I'm sure they don't want to get a call over the weekend. Educational publications. These are available to you online as well as in print form, and you can order them or read them online for you. And these ones that you see stars in front of, those are newer publications. And also, if you do already have the patient handbook, or if you've read it in the past, it has been updated. As you know, myeloma information changes quite often, and it is very important for you to have the most up-to-date available information. A little blurb about the support groups and the importance of support groups. Today, we're going to be talking to you, and you're going to have all of these resources available to you, but we at support groups are available to you 24/7. We have local support groups as well as virtual and special interest groups available. And this is the support group team. That's Becky Bosley, myself, Cecilia Romero, and Nancy Bruno. And you can contact us there at the email sgteam@myeloma.org. And if you don't know where your support group is locally, you can go to this website. It's support.myeloma.org. And you can click right here is a live link. So once these slides are downloaded onto the IMF website, you can click right on this map and you can find out where your closest support group is or your special interest group that's virtual. And if there's not one near you, call me. I'm happy to help you and get one started. So when I talk about special interest virtual support groups, people often ask me, well, what does that mean? So these groups serve an additional supplemental need. So for example, if you're a myeloma patient and you are Spanish speaking, and maybe you are going to your local support group, sometimes it may be difficult for you to understand all of the terminology. It's hard enough in English. So we've created a special interest group called Las Voces de Myeloma. It is 100% Spanish. The meeting is in Spanish. The website is in Spanish. All the presentations are in Spanish. And so for the rest of these, Living Solo and Strong, that is for patients that do not have a care partner. And today, more than ever, that's really important with our newer therapies and bispecifics and CAR-T, and how important it is to have a care partner or a team. Who is your community, your team that's going to be able to help you? We have a high-risk myeloma support group, a smoldering myeloma support group, a support group for younger patients that have younger families, and how do you deal with those challenges. And then I'm so pleased to share with you that starting in June, we are going to have a care partners only support group, and you can find more information out on the website that I had just shown you. And now it's always my pleasure to kick this off and ask Dr. Joe McHale to please take it over with our first topic of Myeloma 101.
Awesome. Thanks so much, Robin. Such a pleasure to be with you always. And of course, with great friends like Kim and Dave. We're so thankful you're both with us here tonight. I'm really just the appetizer in this first section to the main dish, where you're going to hear from Kim Noonan and from David Wiesel a little bit more about how we approach life with myeloma and how we treat myeloma. But for many, we've learned over the years doing these regional community workshops, for many, this is really a new experience for you, and we want to make sure you're equipped to understand the basics of myeloma. Now, let me also add one caveat as I dive in, that even if you are a veteran to myeloma, I would suggest that a refresher with a Myeloma 101 is helpful every once in a while. One, to keep you in the game of what's happening, but also as you explain this to other people. Sometimes it's your family, sometimes it's your friends or others. It's always helpful to know a little bit more about Myeloma 101. So I'm going to, in the next 20 minutes, just give us a quick overview of the basics of blood and why we think of myeloma as a blood cancer, or a cancer that originates in the factory of our blood, the bone marrow. We'll talk about some of the key terms, how we stage and classify myeloma, and then I'll just kind of give you that preview of how we think about treatment. And of course, Dr. Wiesel soon thereafter, later in the evening, is going to share with us more about how we initially treat myeloma. I'll talk to you later about how we treat relapsed multiple myeloma. And then I do want to put a little bit of emphasis here on health disparities, as I have the privilege of leading our program in this at the IMF, and it's just so important. Myeloma is the most disparate cancer within the African American community. We'll chat a little bit about that as we go. So going really simple, going back to the basics, remember that blood is an organ. Obviously, I'm a hematologist. I'm a little bit of a blood geek, so I love this kind of stuff. But, you think of organs like hearts or kidneys, but the blood is an organ, and it's made up of kind of liquidy stuff and solid stuff. The liquidy stuff is called plasma. The solid stuff, we have some proteins in there, as we'll talk about later, but are mostly what we think of as cells. Now, Robin mentioned earlier that we hope that you have a nice glass of water next to you, which is good, but maybe you have a glass of wine next to you too. So let's think a little bit about blood, and I use the analogy of wine because we have three kinds of cells that circulate in our blood: red, white, and rosé. Okay, they're not exactly called rosé cells, but we have red cells, and we have white cells, and we have what are called platelets. So red cells are basically just little red trucks that carry oxygen. That's the way to think about them. You take a deep breath in, oxygen comes into your lungs, the red cells in your blood come and pick up that oxygen and then go deliver them to all the tissues like your brain and your other organs that need it, drop off the oxygen, come back for more. That's pretty simple. That's what red cells do. So that's why when people have a low red count or anemia, they can be tired, they can be weak, they can not have the usual sharpness that they would have because they're not delivering that oxygen appropriately. White cells are like the army, I say. They're like a a force to defend our bodies. In fact, kind of like we have 5 major branches of the military, we have 5 kinds of white cells that protect us from infections and different things. And then lastly, platelets. Platelets are like, I call them the ambulance. They're like the first ones to get there on a scene. If I cut myself, they get there, they plug up the hole, and they make a phone call and call their friends that are called factors to come and solidify a blood clot. And all 3 of these cells are made in the factory of our blood, which is called the bone marrow. And so myeloma is a cancer of a part of that bone marrow where those blood cells are produced. And there's a certain kind of cell called a plasma cell. Now, it's not the same as the liquid plasma that I just talked about. It's a bit unfortunate that that word got used twice, but it's such an important word. It gets used twice. But plasma cells are cells that live inside the factory of our blood. So even though the factory makes red cells and white cells and platelets, there's a lot more to this factory. There's a lot more complexity there. Just like, you see cars that come off the assembly line, inside the factory is much more complicated. And that's why sometimes a blood test is enough, but sometimes we need to go inside the factory and do a bone marrow test. And so when we look in people's bone marrows, we find all these different kinds of cells that produce the white, red, and rosé that we talked about earlier. Within that is a small group of cells called plasma cells, and these are really good. We like plasma cells. In fact, plasma cells are critical to our existence because they are the cells that make antibodies, or, in medicine, we like to use words that patients don't understand. We call them immunoglobulins. That's just a complicated way of saying antibodies. So if Robin gets her flu shot this fall, which I suspect she will, when she gets her flu shot, that is a message that actually gets sent to her plasma cells. And those plasma cells respond by making an antibody or a certain kind of protein that helps fight off the flu if she gets infected. And that's what normal, healthy plasma cells do. When those plasma cells become cancerous, which is what we see in multiple myeloma, those now same plasma cells, instead of making good antibodies that fight off infection, now paradoxically, they make bad antibodies. And those bad antibodies can damage the skin. And we sometimes call these antibodies or these proteins M proteins or monoclonal proteins because they're identical. I mean, that's really what cancer is. Cancer is identical, uncontrolled growth, where it grows out of control. Just like you can think of a piece of breast tissue or colon tissue or lung tissue, here we have these plasma cells that are growing out of control. And so when we think of the types of myeloma, it kind of depends on these different classes of antibodies or immunoglobulins. And so we have what are called immunoglobulin G, immunoglobulin A, M, D, and E. So we technically can have myeloma of all of those, although it's much, much more common to have the IgG version or the IgA version. It's about 2% of all cancers. The average age of diagnosis is in our late 60s, about 69, although as I'll share with you in a few minutes, it's considerably younger in African American and Hispanic or Latino American patients by about 4 to 5 years. If we look back to last year, we had about 35,000 new cases. It's tragically about 13,000 deaths. And sadly, the mortality or deaths from myeloma is twice as high in the African-American population. What I mean by that is, a Black man or Black woman diagnosed with myeloma today is sadly expected to live half as long as a white man or white woman of the same age for lots of reasons that we'll describe a little bit later. That being said, I want to be very positive here because we have seen a huge improvement in survival in myeloma. The average patient now with myeloma actually lives more than 10 years. Now, of course, that's only an average. Some people sadly still die within the first year of their diagnosis. And we have other patients that have lived 20, 30, 40 years with this disease. And so it really has a large spectrum across the board. And just to dive deep a little bit more on these types of myeloma, I told you that there was IgG, IgA, and IgM, et cetera. But these proteins are a bit complicated. They're like a Y-shaped thing. And so there's what we call the heavy chain and the light chain stuck together. But there are some patients where these little bits of light chain kind of fall off or only are produced by the myeloma cells. So about 20% of myeloma patients have what's called light chain only disease. So when we do blood tests, we have to look for for that M protein or the monoclonal protein, as well as the light chains. And then really it's probably down more to 1% of patients. Now, there are some patients that have these plasma cells growing out of control in the bone marrow, but they don't make any antibodies. And so they're what we call non-secretory. And that can be difficult to make the diagnosis because typically we think of myeloma when we see that protein in the blood. So again, to look at it just in a different picture to help you understand it, that big conglomerate of the blue and the red together here is what an immunoglobulin typically looks like and what an M protein will look like when we measure it in a myeloma patient, but there's also the light chain only as well. This is how we do it in the lab. In case you're of lab interest, this is what normal proteins in your blood should look like. We've got this, what looks like a mountain peak and these little tiny hills, kind of like the hills here in my backyard in Scottsdale, where we have these little hills, and those are all the normal proteins of your blood. And if you look on the right at the bottom, there's the IgG, there's the IgA, there's the IgM, and then there are the light chains. One of them is called kappa and one of them is called lambda. That's why it's K and L. So this is what your blood really should look like. When someone has myeloma, we've got this extra bit in that one area of concentrated bad protein. And that's what we call an M spike. And that's why your doctor, your healthcare team might say, oh, your M spike measured at this, or your M spike measured at that. This patient in this example has what's called an IgG lambda monoclonal protein, or M spike, that we can now measure. And as we treat a patient, we want to see that disappear, right? It's not simple like lung cancer, where there's maybe like a tumor that we measure with a ruler on the X-ray, and we want to see it shrink down. Here, it's a blood test that we measure in the form of the M spike. And so as these bad plasma cells make these bad proteins, we can measure them in the blood. Now, what's interesting is that myeloma, which is pictured in red here, has very tight definitions because, interestingly, it's very common for people to actually make just a little bit of this abnormal protein. As we get older, it's not uncommon for a few of our plasma cells to kind of go off the rails, as it were, and make a little bit of this bad protein. And so it's so important for us to distinguish that, what I say to my patients, is a little bit of dust in the corner compared to a huge pile of dirt that we need to address. So there are three categories here. The first category is called MGUS, or monoclonal gammopathy of undetermined significance. It's a big mouthful. It just means that someone has a little bit of this bad protein, but it's not hurting them, and we don't need to do really anything to treat them, but we have to monitor them because a small percentage of these patients will go on to have active disease. At the other end of the spectrum, what's in red, as I mentioned, is myeloma. And we define myeloma by having more than 10% of your plasma cells in the bone marrow. So normal is less than 5%. Most of us have about 1 to 3% of the factory is myeloma or plasma cells. So to be myeloma growing out of control, it's over 10%. And they have some kind of what we call a myeloma defining event, where it's basically either already damaging the patient or about to damage the patient. And this is what the focus of the rest of our talk is going to be. But in the middle, there's something called smoldering myeloma, where they have a little bit more protein than the MGUS patients. They do have more than 10% plasma cells, but they've not yet damaged or about to damage the body. And so this in-between space is where we do a lot of research and work trying to figure out, why does someone go from MGUS to myeloma? Do we have to treat smoldering myeloma? No, I just saw 2 consults in my clinic today on this very question. I have smoldering myeloma. Do I need to be treated, doc, or do I not need to be treated? And we want to walk that careful line of not over-treating someone who may never develop myeloma, but we also don't want to wait until someone breaks a bone or starts causing damage to be able to treat them. And that's why the diagnosis can be challenging, because it's not like someone feels a lump or sees blood in their urine or their stool like we sometimes pick up other cancers. The diagnosis, typically people are tired. People have some kind of bony pain, or people have anemia or a low red blood cell count if they've been tested. Well, each of these 3 things are really common. And so that's why it's sometimes difficult to capture them off the start, but it's often how, and we work very closely at the IMF with educating our primary care and family physician friends so that they can try and pick this up a little bit early. But those myeloma-defining events, as I mentioned, for many years, we used to call them CRAB, which was an acronym to remember that they had a high calcium level, they had renal or kidney damage, they had anemia or a low red blood cell count, or they had bone disease. But recently we added 3 more criteria: that if they do have more than 60% plasma cells, if those light chains, the involved over the uninvolved light chains, when we do the blood test, is over 100, or if they have more than one focal lesion on the MRI, that indicates that their diseases become more active. And so we put this all together now, call it SLIM CRAB. So if someone has more than 10% plasma cells in SLIM CRAB that we can attribute to those plasma cells, we basically call it myeloma. Other things can happen too. People, as I mentioned, can be fatigued. They can have weakness. We don't fully understand it, but myeloma seems to have a love affair with the nervous system in the body. And so sometimes people can have neuropathy, and that could be one of the ways it's diagnosed. Now, I won't take time to go through each of these, but for many of you, this is what you see every week or month as you go and visit with your healthcare team. But understanding these blood tests becomes important, that we check those red, white, and rosé cells. We look at the biochemistry of the blood to look at things like your calcium level and your kidney function. And then particularly important is looking for that monoclonal protein, doing those blood tests that we call the serum protein electrophoresis and the light chain measurements to look at someone's myeloma and follow it. Now, I haven't gone into this a lot of detail, but briefly, let me also say, not very commonly, but we do know that sometimes we can't measure it easily in the blood, and these proteins find a way to get into the urine, the way they interact with the kidney. And so for some patients, you are following your urine as well and doing a 24-hour urine collection on a regular basis. And so this is just a little bit more detail for you about these different tests that we do. Again, I won't read them all for time's sake, because we just want to make sure this is as a resource, and we can make these available to you to understand all the different tests that we do. But I just want to focus in the middle for a minute in what's highlighted next to the word SLIM, that we think a little bit about these specific protein tests that look for the myeloma. You know, sometimes I say to my patients, myeloma is like a crime scene. No one piece of evidence tells you the whole story. So we need the blood test from the basic CBC. We need the chemistry. We need the protein test. We need a bone marrow. Sometimes we also need to do imaging, x-rays. And it's putting all those things together that makes sense. And sometimes there may be discordant things. I saw a patient today where one level was going up and the other level was going down. And she said, Dr. Joe, I don't understand. Like, how can this happen? And sometimes it's complicated. But overall, we look at the general overview of what's happening with the disease to make a decision. When it comes to imaging, as I mentioned, or x-rays, we used to use pretty simple plain x-rays, and they're helpful if there's a lot of damage, but there has to be a lot of damage for a plain x-ray to pick it up. So now we try to use more sensitive techniques, things like a CT scan or a whole body low dose CT, or even a PET scan, and sometimes MRI, and that can give us a much better visualization of what may be happening in multiple myeloma. And then, of course, the bone marrow test itself, and I know it's not the best thing to go through and have someone stick a needle in your backside, but this becomes important because that's where we find the headquarters of myeloma. As I said before, if I want to evaluate a car factory, I can look at the cars that came off the assembly line, but I really want to understand it, I go in the factory. And we go into the factory, look for a few things. We look for the actual plasma cells themselves, and what percentage are they? How do they look? And then we look at the genes of those plasma cells. You'll hear us talk about something called fish. Go fishing. We want to fish, which is where we look for the kinds of genetic abnormalities. Now, these aren't genetics that you pass on to your children. These are the genes of the plasma cells that can help us distinguish, does someone have standard risk myeloma or high risk myeloma? You know, I mentioned that we have some patients that live a very, very long time with myeloma, and sadly some that don't. And a lot of that distinction is the kind of myeloma that someone has. We think of it as one disease, but it's really a spectrum. People can have what's called standard risk or high risk multiple myeloma. And that leads me to the staging and the classification. Again, lots of letters and numbers and confusing things here. I don't want to go into too much detail, but we do have a staging system. Let me just first say that the staging is not as critical perhaps as with some solid tumors like colon cancer, lung cancer, where staging tells you everything. Here, it's really, does someone have myeloma that needs to be treated? And do they have high risk or standard risk? And that high risk is usually defined by those FISH techniques. So when you look at that table on the bottom left, when people have these different genetic abnormalities, sometimes they're missing a chromosome, sometimes there's extra bits of chromosomes, sometimes they're chromosomes that normally should be separate that get joined together. Those are the things that help us define high-risk myeloma. And then as I come towards the end here, it's important for us to realize that treatment is not about going to a doctor. And I know Dr. Wiesel, for example, would never say this. You know, you don't look at a doctor who tells you you'll do it and you'll like it. You know, that's not how we do it. And Kim is going to talk to us in a few minutes about the importance of the dialogue and the interaction we have with our healthcare team. But as we plan, we put all this information together and we think about what's important to you, your own health, your age, your circumstances, and then try to piece that together to the best treatment plan. And that plan typically initially says, are you so-called eligible for a transplant or not? And I know Dr. Wiesel will talk a bit more about that because we know that transplant can really help people. It's a method whereby we give a high dose of chemotherapy to patients to really get rid of those angry plasma cells that may be left. But as we make these decisions and as we treat the disease, we know that sadly, the disease inevitably, almost invariably does come back again. And so-called it progresses or it relapses. And so we want to develop more treatments for relapse myeloma. And one of the most exciting things about the myeloma community right now is that we have more treatments than Dr. Wiesel and I ever had back in the day. I can tell you that. When I started in myeloma, you know, we had 1 or 2 drugs. Now we have about 20 drugs that we can use in myeloma, and thankfully many, many more to come. We do comment about the importance of being able to seek an expert or second opinion because myeloma is really complicated and it's helpful to get other advice. Oh, sorry, I jumped ahead here. I'm not going to go through this. I do this really as a resource for people, and you can find this on our website at myeloma.org. But just to almost overwhelm you at the number of drugs that we have. I mean, Dr. Wiesel will join us shortly. Kim, I know you're going to join me shortly, but can you imagine when the three of us started working in the myeloma world that we would be giving a talk together one night where I would show these 2 tables full of drugs for myeloma? It really is remarkable how much progress has been made. Not to mention some of the things that I'll describe later about different new ways of leveraging the immune system to treat myeloma, something we call antibody drug conjugates, something called CAR T-cell therapy that I'll briefly talk a little bit about later, and indeed these new drugs called bispecific antibodies. And those 3 drugs or classes of drugs that I just described are all about finding ways to engage someone's immune system to treat their multiple myeloma. And what we do is we leverage the fact that myeloma has all these things that stick out of it, and we grab onto it to help destroy the multiple myeloma. And so here I come to my end and say that it's remarkable how many drugs we have and how the field has evolved. We still have a lot of work to do, however, and in one area in particular that we've been seeking to address at the IMF, it's in health disparities. We know that African Americans and Latino Americans are not only younger when they're diagnosed, there's a longer time to make the diagnosis. They're less likely to receive these key treatments that we know have changed survival in myeloma, like combination therapies, like transplants, like clinical trials, like CAR T-cell therapy. And we know that, as I shared with you from the start, that outcomes or survival is half that of white patients when we look at the African American population. That being said, we know we can do better because we know when that access is granted that African American patients can do just as well. And that's why we're so committed to reducing these disparities. And we work through a program that you can read about at empower.myeloma.org, where we seek to, in 3 ways, engage the community, educate the primary care world, and enhance the care of patients with myeloma so that we can improve and reduce that disparity. We do this in city by city across the country, as well as a national effort to try and overcome these disparities. And of course, as Robin so beautifully shared with at the start, there's only so much we can put into a few hours of our virtual workshop like this. We have all the resources you could imagine at myeloma.org. It's my privilege to oversee our publications at the IMF, and we have so many amazing things. In particular, this handbook and understanding your test results when you're first diagnosed with myeloma. We encourage you to get those 2 booklets because they're of such help to newly diagnosed patients. And with that, I'm going to turn it over to one of the most extraordinary nurse practitioners I've met in my career, who I know understands this disease inordinately well and provides outstanding care for her patients, not only in Boston at Dana-Farber where she is, but has educated patients literally around the planet. So Kim, I'm going to turn it to you and talk to us about this concept of taking the reins of your multiple myeloma care. I kind of feel like I got to get up onto a horse here. And so I'm going to turn it to you and let you carry on. Thank you so much.
Dr. McHale, thank you so much for that introduction. It really is an honor to be part of the myeloma community. It's an honor to be here this evening. And you're right, this is about taking control and navigating your disease. And, you know, during this season where it's the Kentucky Derby, I think Preakness was this weekend, you can kind of, you know, engage me and in my talk. So what I plan on talking about for the next few minutes is, you know, looking at, you know, your knowledge, giving you the knowledge of the disease, the treatment, and how to navigate symptoms that you're having. So much of it is so important for you to communicate to your providers about what you're feeling, but also knowing your team and shared decision making. So, you know, for example, for you, maybe it's important for you to get oral therapy. That's, you know, those are the goals of your therapy. It's important to sort of communicate that and going the distance. And that's really maximizing, you know, your quality of life, optimizing your health. And we're going to talk about all of that. So with that, we're going to turn it over. First, we're going to talk about, you know, the side effects, treatment options, and what are the treatment goals. And so here we have the myeloma therapies and then the supported treatment, and what are the goals of each one of them. Certainly for myeloma therapy, everybody really wants, you know, maximum control of their disease, a durable disease control for an extended period of time. We have that with maintenance therapy. As Dr. McHale pointed out, you know, the average age is for people to survive 10 years. In my practice, I see 10, 20, and even 30 years. But, you know, on both sides, it's promoting your quality of life. And so we can't really promote the quality of life if we don't know what's going on with you. And so that's sort of, I think, the intent of a lot of, you're going to hear me say like, oh boy, would she just stop? Quality of life, but it really is about your quality of life. And then supportive treatment. You know, what can you do to prevent disease and treatment-related side effects? And what can you do to optimize your symptom management? And by just discussing, you know, this with your team, it's amazing what we have in our armamentarium to really treat you to maximize your quality of life. And so with that, you know, we're going to start with, I don't know, something kind of the good, the bad, the ugly. It's steroids, right? It's sort of the disease. It's sort of the drug that we love to hate, but we need it, right? Why do we need it? It enhances the effectiveness of so many of our myeloma therapies. You know, currently there are therapies that we are not giving as many steroids that we were at the beginning, but still, it's a very essential part of what we do. And when you look at the side effects of steroids, over to your right, it's that irritability, that mood swings. I often tell people, please don't, you know, buy a new car or a house when you're kind of crashing on your steroids. Difficulty sleeping. People often say, you know, I've gained weight. I've gained weight right in the middle. My hair is thinning. It's really kind of a tough drug, but what can you do to control these symptoms? And some of it is, you know, consistent scheduling. I have patients that wake up in the middle of the night to take their steroids so that the following night they're going to be able to sleep. They're able to go back to sleep, maybe get, you know, a few more hours in. Very important that you take your steroids with food, as I think most people know. But also looking at, you know, the over-the-counter medications to control some of the GI issues that you might have with steroids. And so, you know, with that, you know, we need to take sometimes medications if we're on large doses of steroids to prevent things like shingles or maybe other infections, which brings us really to the next symptoms that we're going to talk about, which is infections. As Dr. McHale pointed out, this is a disease of plasma cells. And, you know, plasma cells make antibodies. So with that, people often develop infections, maybe from the therapy, but maybe also from the disease. So if you have a fever, maybe shaking chills, even without a fever, you want to call somebody. If you have shortness of breath, or low blood pressure, urinary frequency, you need to call somebody. So the IMWG in 2022 published some consensus guidelines and recommendations of infections. And we're starting to see with bispecifics as well as with CAR T, there's a whole nother host of infections that we're dealing with. But, in general, we want you to think about the fact that, you need to have good personal hygiene, for example. Immunizations, we have recommendations for your immunizations. Talk to your healthcare providers about that. And also environmental control. Like, we really don't want you sort of at, a concert in the middle of a mosh pit. Avoid crowds and avoid people that are sick. We're just coming out of COVID. And so I think everybody really knows, about the importance of all of that. And when you think about, prevention and supportive medicine, we're going to see here that probably many of you are taking medications like acyclovir to prevent shingles, or maybe you're taking sulfamethimazole or Bactrim to prevent pneumocystis. And so, you may also be taking something like levofloxacin if your counts are really low, or if you are predisposed or have an infection, fluconazole for fungal infections. IVIG is a medication. It's an infusion that we give people. It's an infusion of IgG. When your IgG is less than 400, and even if your IgG isn't less than 400, but you have a lot of infections, IVIG may be something that your providers will consider. So just to take a step back and look at, your white blood cells when they're low, and specifically when your neutrophils are low, you may be getting a white blood cell booster called GCSF to increase your white blood cells. We can give this anywhere from 1 to 3 times per week. And, it's very, very effective. I'm sure that many of you have already received GCSF in your treatment. And so for, COVID-19, certainly we know that there are vaccines that we can use. There's a new drug that was just FDA approved in the last few weeks for people that are at risk for developing COVID-19. And so these are things that you want to talk about with your provider. And as you can see, this is a lot of information. I think you'll have the slides so that you're going to be able to take this back to your providers. And so we're going to turn it over to GI symptoms. And so there's a few of them here. One is diarrhea, one is constipation, one is weight management. And so first and foremost, what causes all of these? And, in my mind, I'm often thinking about the therapy that people are receiving. And so that's really going to cause a lot of GI issues. I'll often say to patients, we're going to start you on lenalidomide, which is Revlimid. It may cause diarrhea. It may cause constipation. I don't know where you're going to fit, but talk to us about your symptoms. And so diarrhea really can be caused from antibiotics that we give you, as well as antidepressants, but things like magnesium or laxatives. Maybe you were constipated and then you took laxatives, and that did such a great job that now you have diarrhea. And so, think about maybe what caused it. Think about, your diet, and is there something that you can do that could improve your symptoms? We all, so for medications that you want to take for diarrhea, it's things like Imodium or Lamodal, Cholesterol, if it's lenalidomide related. And so for constipation, opioids, so drugs like morphine or Dilaudid, codeine can cause constipation. It's sort of the universal side effect that we think about when people are taking pain medications such as an opioid. And so antidepressants can also cause constipation. And we also saw that antidepressants can cause diarrhea. But blood pressure medications as well. And so think about what you can do in terms of your diet. Maybe you need to increase fiber. You need to be more mobile. That's going to help your constipation. But you can also try medications like Metamucil or Senecot, as well as Miralax, for example. But pay attention to that. Also, fluids really needs, you need to think about fluids. Fluids are going to help diarrhea if you're losing a lot of fluid from that. But also for constipation, for example, you need to have, sometimes more fluids can help you move your bowels. And weight management, we have a great nutrition group here that can meet with people if weight is an issue. Steroids can cause weight gain, and these are things that you can talk about with nutrition as well as with your provider. So, lots of things that you can do to navigate these symptoms. as well as pain management. And so when you think about pain management, I often think, what can we do to prevent that? And things like bone strengtheners, zoledronic acid or denosumab to decrease fractures, certainly are, really a standard of care for our patients. Antivirals, for example, to prevent shingles, very, very important, as well as maybe, the shingles vaccine. And things like sedation before a procedure, so often if we do a bone marrow, people don't have any sedation, they're going to really sort of tense up, and that's going to cause a lot of pain even after the procedure. And so the interventions for pain really depends upon what the source of the pain is. So we can do, if it's, unfortunately a fracture, we can do radiation, but, maybe there's a surgical intervention that needs to be done. Medication certainly is something that we're very familiar with providing for our patients. Complementary therapies, just really work. And, I know where I work, we have a complementary therapy department that is very active. We do yoga, we have a chiropractor, we have an acupuncturist. So, just try to think about what it is that, you have in your community that you have access to. Try things. You never know until you try these things. All right. And so another symptom that people will often present with is insufficient sleep. And it's so important to your health. And so what interferes with your sleep? Well, steroids, the drug that we, love to hate, but herbal supplements, for example. Sometimes if I'm trying to sleep and all of a sudden my brain won't shut off, guess what? I'm not sleeping. And so it's anxiety, for example, can really interfere with your sleep, as well as sleep apnea, physiologic issues like heart issues, or even pain. And so, why are we so focused on this? Well, insufficient sleep is going to weaken your immune system. It could cause an increase in anxiety, worsen your pain. And, as you get up and you're groggy, you can have, injuries as a result, but you can have heart-related issues as well. So very important to have sleep hygiene. And I say to patients all the time, if you're in bed, you're tossing and turning, get out of bed, do something, fold the clothes, do something, and think about maybe have a warm bath or tea, and then try to go back. But I think just sitting there and focusing on trying to sleep really makes you not sleep. And so sleep hygiene is very important. And computer screen time is also a part of this, and eating large meals, spicy foods. You're not going to sleep if you have all of that. Nicotine, alcohol, sugar, caffeine are all really going to impede your sleep if you're having trouble sleeping. I mean, how many people do we know that can have a cup of coffee and then go to sleep? But, so many of us are not like that. So sleep aids may be needed, and you should talk to your provider about that. But certainly sleep is important, and we will do whatever it takes as on the provider end to make sure that you're really living your optimal life and sleeping in adequate amounts. So peripheral neuropathy is something that Dr. McHale also addressed, and so much of our treatment can cause peripheral neuropathy, as can the disease, multiple myeloma in and of itself. And so, when we think about peripheral neuropathy, we often think about the proteasome inhibitors such as bortezomib or Velcade, or carfilzomib or Kyprolis, ixazomib or Ninlaro, as well as lenalidomide in and of itself can cause peripheral neuropathy as well. So much that we can do for peripheral neuropathy when we know that it exists. For example, we can adjust your medication. So if it's bortezomib or Velcade related, we will decrease the dose, or maybe instead of getting it every, for 3 weeks on and 1 week off, we might give it to you every other week. So we're really willing, I think, as the providers, to make sure that, you're not experiencing peripheral neuropathy. But, peripheral neuropathy, how does it sort of present itself? It's numbness, it's tingling, it's that sensitivity to touch. I often see people say, my feet are freezing. And then when I warm them up, they're sweating. So these are the symptoms you want to talk about with your providers. And so cocoa butter, we have a physician here that everybody well known to the world, and he started off with cocoa butter. We all thought he was like a little crazy, and my patients just really respond to this significantly. And so try cocoa butter if you have peripheral neuropathy. Also vitamin B complex medications as well, but there's also medications such as duloxetine or Cymbalta that you can take, gabapentin or Neurontin, as well as Lyrica, which is pregabalin. So you can take. There's so many interventions that we can use for peripheral neuropathy. All right, and so turning it over to the next symptom, which is kidney function. And so we know that myeloma patients could experience kidney issues at some point during the trajectory of their disease. And so it's very important to prevent this, and you can do this by staying hydrated, but to avoid certain medications like NSAIDs, like ibuprofen. We may have to adjust doses as needed. But risk factors include active myeloma, like light chain disease, or people that present with high calcium. Other medical issues, diabetes, an infection can increase your risk of kidney function, as well as antibiotics or even contrast dye. And so the treatment, sometimes when it's myeloma, we're going to treat that disease right away. And it's amazing that, kidney function your kidney will really respond to the myeloma treatment in so many situations. Hydration is key to all of this. And so I often say to patients, when you wake up, just have a bottle of water beside you. Have a bottle of water beside you all day long, and get off to a good start with fluids. That's sort of one of the things that you can do really to help yourself. And so look at this long face on this. Do you think he probably didn't win the Kentucky Derby? Probably not. And so I think the long face is because of the symptoms that often people present with myeloma, like fatigue. So it says 98.8%. It's more, so essentially it's 100% of the most common reported symptom. And, sometimes it's due to pain, or maybe it's anemia, bone marrow suppression. Maybe it's just insomnia. You haven't slept for days. Talk about it, because there's so much that we can do. Anxiety as well, and depression. Anxiety in greater than 35% of patients. I think it's probably higher than that, and depression as well at about 25%, probably higher than that. Sharing these symptoms with your providers it's just really going to make a difference, as well as with your the caretaker support as well. I love this slide because it really gives us a wealth of information about supportive care when it comes to thrombosis or deep vein thrombosis, pulmonary emboli, bone health, and fatigue, as well as anxiety. And it goes into what the support, I really won't go into a lot of it, but supportive medications, what some of the non-medication therapies are, and then the lifestyle options. And so I really want to draw your attention to the bottom line here, where it says, the lifestyle options across the board is activity. And so one of the most important things that you can do with people with this disease is to stay active. The other thing too, when we talk about fatigue and we talk about anxiety, is the complementary therapies or the non-pharmacologic therapies as well. All right, and so financial burden, contact social services department at the hospital or clinic to talk to a social worker if you're feeling financially burdened. And so many are, because with this diagnosis comes comes time off from work, or maybe a loss of employment, right? What about the caregiver too, who also needs to take time off? And then, we put that on top of the fact that there's prescription costs, there's travel costs, there's co-payments. It just goes on and on and on. And so it makes sense. And also the fact that people really do live a very long time with this disease. There's a lot of financial burden over the years. And so there are federal programs that you can tap into. There's pharmaceutical support. There's websites that I really encourage you to take a look at that really, want to help you to overcome the financial burdens of all of this for such a lengthy period of time. And so Dr. McHale got into the fact that, we have CAR-T therapy. We're going to get into exactly what that is in the next lecture. But cytokine release syndrome is one of the most common side effects that you might see. It's very common, often mild, It's manageable. These are the side effects that you're going to see: fever, fatigue, headache, confusion, a decrease maybe in blood pressure. We know how to manage this. I mean, we're looking for this in people that receive CAR T or bispecifics. We're looking for this side effect, and we know how to manage it. The other side effect that is not as common is neurotoxicity. It's rare, but very serious. And this can happen later into the CAR T or the bispecific infusions or, over time. And it can even happen months later. And so these are some of the side effects that people are going to present with headache and confusion and altered wakefulness. And we actually even have different surveys that we give patients on a very regular basis to make sure that they're not experiencing neurotoxicity or CRS. So we'll talk more about that later, and I'm sure that there'll probably be questions about this as well. All right, and so we're going to talk about, the next part is going to be empowering you as the patient and engaging in the care. But, certainly the fact that you're not really riding this alone, but there's so many people that are in your care team, right? And so who are they? I think it's important to know who they are. I actually have patients that bring notebooks and they'll actually have a picture of us and say, this is Kim Noonan. She's my nurse practitioner. This is our research nurse. This is what she looks like. And so we'll start with the myeloma specialist here. It's Dr. McHale. Look at him. And so really going to a specialist, but maybe being treated out in the community by a general hematology oncologist is very common. It's very common for people to do. You really don't want to have to, if the myeloma center is miles away, you want to just sort of limit the amount of time you need to be there. We're very willing to work with people in the community. We love to work with people in the community. And really, it's one of our goals is to really educate and communicate with all providers. You need your support network. That is essential. In your allied health staff, it's certainly going to be RNs, it's going to be infusion. Maybe you have a research nurse, maybe you have an oncology nurse navigator, and then maybe a physician's assistant, for example, a physical therapist. There's subspecialists that are going to get into your care as well. Orthopedic surgeons, cardiologists, pulmonary, physicians as well. So all of this, as well as what role does your primary care have all of this? And, well, baby care is essential, but maybe you want to go when you have an upper respiratory infection, and they're very important. So keep your primary care provider. They're kind of a hard person to come by. And then your pharmacists. I don't know what I would do without the pharmacists that work side by side with us, and they're a very essential part of our team. So communicate with your team, understand the role of each of the members, bring questions to your team, and make sure that they're answered. And if they're not answered, just keep asking the question. I think it's essential that as the most important part of the team, that you understand exactly what's going on and that you have lots of options in terms of treatment, which we'll get into in the next lecture. And so, your team is able to help, as I've said several times, but, we need to know how you feel. And so are your symptoms from the myeloma or are they from the treatment? And so GI symptoms, we talked about from the treatment usually, but maybe an increase in your calcium might be due to your disease. And so it's just really important for us to know the infection risk is on either side, neuropathy on both sides, and fatigue. So there's, we need to know where they're coming from, and we need to think about that. Knowledge is power, and you're not alone. I think we've said that a few times throughout this talk, and we'll say it a few more times. But, what can you do? And really what you need to do, and really this is sort of the prescription that I give to you, and that is to maintain your health and do everything you can to just have an optimal life. And by doing that, we really want to make sure that, you have a primary care, that your blood pressure is well maintained, which we'll get into in the next slide. But when you think about, going through all of this, it's your care partners that are also engaged in all of this, making sure that some of them are managing medications and going to your appointments with you. It could be a spouse, it could be a friend, but it's nice, it's important, I think, to really find out and locate and realize who your care partner is. And recognize that the care partners, this is a stressful place for them as well, that they need to maintain their health. Going through all of this. This is going to be a very long journey for everybody, which is the good news. And also for you, why should you have social ties? Well, there really is a lot of data, as I sort of get into this more and more, that people that have more social ties, and this is not just in myeloma, but in all oncology diseases, it increases your longevity. And that also your adherence to medical treatment, your overall survival is enhanced when you have strong social ties. And, you sort of say, well, why don't these people call me? I used to have so many friends, now I don't. Sometimes you need to reach out to people, like put yourself out there. People, probably don't want to bother you. They know you're busy. Put yourself out there and, and contact people that maybe you haven't been in touch with for a while. Maintain good health, as I said before, and you can do that by doing the well baby care with things like colonoscopies and having a mammogram and having your PSAs done, but making sure that your blood pressure is well controlled. Maintain your weight. As we said before, you need to be active and you need to have, wonderful sleep, right? Don't you wish we could all have that? And so, an ounce of prevention is worth a pound of cure, as Benjamin Franklin said, and he couldn't have been so right. He said it so many years ago. And so with that, I'm going to look forward to the questions that you'll have after we hear from Dr. Batesco. Thank you.
Good evening and good afternoon, depending on your time zone. It is an absolute pleasure for me to be here. And I don't know if the audience really appreciates it, but Kim and Joe are some of the finest speakers I've ever heard in the whole area of myeloma in my life. I kid you not. I'm honored and humbled to be on the same program with them because they are so good. I strive to do as well as they do. So thank you to Joe, to Robin, to the IMF, and to all the sponsors for giving me the opportunity to participate in this regional community workshop. I really appreciate this. So I'm a hybrid, which is a little bit different, I think, than what Joe is. I do myeloma 80% of the time, but I do transplant / CAR T cell 20% of the time. So I actually do inpatient and outpatient care, and I refer patients not only for transplant, but also for CAR T cell, and I take care of them at the same time. And I've been doing this, Joe's talking about back in the old days, but I probably got 10, 15, 20 years on him. So I'm not sure what he's talking about when there was only 1 or 2 therapies. I actually started doing myeloma in 1990, guys. And I want to tell you a positive story before I get started with my talk. On my desk, I kid you not now I'm at home. On my desk, I have a photograph of a family of one of my patients who in 1992 underwent a stem cell transplant. A gentleman from Pennsylvania, when I was at the University of Arkansas with Dr. Barleggy and Dr. Jagannath. 1992, he's still in remission. 32 years later, he sends me a holiday card every year. And I keep it on my desk. Not giving you a line. It's an inspiration to me to do that for as many people as we possibly can, as we try to combat this disease that everyone quotes unquote incurable. I'm probably not before I retire, but I feel confident that at some point in time we're going to be able to cure this disease. So with that, the first step to curing anything is talking about frontline therapy, because you got to get from point A to point B. So this is the objectives. We'll skip that. So this is a difficult slide. So let me just give you, I love this because it's an iceberg. The Titanic didn't see the iceberg. The Titanic ran into the iceberg. The Titanic crashed. And of course, we've got a great movie and we've got great mementos from Titanic crashing, but that's really not the point here. The issue with myeloma, which is so much more difficult than almost any other cancer, is that For example, in leukemia, if you have acute leukemia, which is a bad thing to have, you either have it or you don't have it. It's yes or no. Myeloma has all these different levels of response, which is represented on this slide here, this photograph. So at diagnosis, you have 1 trillion cells. And then if you have a 50% reduction, you have 500 billion cells. We call that a partial remission. If you have a 90% reduction, you're down to a little over 1 billion cells. And if you get what we consider a complete remission, you have 10 million cells. And then the goal, the current technology says we should strive for minimal residual disease, which means when they do some sophisticated technology, you can find less than 1 myeloma cell in 1 million cells, 1 million plasma cells. And Joe talked to you about the different types of blood cells. Well, we all have normal plasma cells because they make antibodies to fight infection. So if you can find less than 1 myeloma cell in 1 million plasma cells, we call that MRD negative. And we do know that the deeper you go on this slide, as you hit the end of the point at the bottom, the deeper you get, the better your outcome. So our goal presently is MRD. And I can tell you already that one of the questions that's been thrown into the chat boxes is, what do you do with MRD if it's not positive? It is positive, very controversial right now. All I can tell you for MRD, and Joe may deal with this later on in his relapse talk, is MRD does indicate a fantastic level of disease control. Whether we should keep banging on people to reach that level, should we change their drugs if you don't have MRD negativity, still not known. It's a good thing to have. We're not really sure what to do with it if you don't. So anyway, myeloma is difficult. It's not yes or no. There's all these different levels of responses, and this doesn't even include the radiologic reactions or responses, because there's PET-CT responses, there's MR responses, and it's very, very confusing, which is why most physicians steer clear away from myeloma. It's too complicated for them. All right, let's skip all this. So we talked about that. Treatment, you kill things, that's good. And this is just summarizing what I showed you. If you get to MRD negativity, when you look at the amount of cells you have left, it goes down, down, and down. So MRD currently is 1 in 1 million cells. I can't imagine, there's already some tests that they can probably pick 1 in 10 million cells. So this is technologies that keep advancing to try to prove that you have less and less myeloma versus the crude, just looking at that protein electrophoresis, the free light chains that Joe talked to you about. This is a molecular technology, and it's much, much more sophisticated, sort of like comparing a black and white TV with a high definition TV or smart TV. This is the latest craze in detecting the degree of response in patients with myeloma. And this summarizes, so these plots, these curves are called Kaplan-Meier curves. The curve on the top is the group that does the best. The curves less than the one on the top do less well. So they put these, no-brainers on here in the yellow boxes. CR, complete remission, which is what CR stands for, MRD negative. And you see that does better than if you're a CR, that does better than if you're in a VGPR, it does better than if you're a PR, which I already talked about before. The deeper the response, the better your remission duration, the deeper the response, the longer the survival. And down at the bottom, and again, I'm sure these slides are available to you. It gives some of this data in months, but I will tell you that a lot of this data is already old. This paper was from 2017. That's like almost ancient history in the myeloma field. So you have to decide on transplant eligible, transplant ineligible. So this is sort of like a Shakespearean quote, to transplant or not to transplant. That is the question. And just as an aside, I want you to know, for people who are Shakespeare fans, nothing to do with myeloma per se, but if you're Shakespeare fans, Merchant of Venice, Romeo and Juliet, which is from Verona, Italy, the guy never stepped foot in Italy in his life. So you don't have to be there to imagine it. just so you know that. So first of all, you have to find out if they're considered eligible or ineligible, and a lot of that has to do with the person you're seeing. A lot of it has to do with where you live. A lot of it has to do with your support system. So it's not a simple yes or no. There's a lot of things involved. I will tell you, I already mentioned to you, I do transplant 20% of my time. So I'm pro-transplant. I can't speak for my colleagues, but I'm a pro-transplant person. And to me, a person I would think is transplant eligible, they may think, oh my God, you gotta be kidding me. But I've been doing this for 30 years, and I have a pretty good idea of who I think can get through a transplant and who can't. So the first thing you have to decide is they're transplant eligible or ineligible. And I will tell you that in the real world, not in academic centers where patients are treated more aggressively as a whole, in the real world, only about 50% of the patients who I would consider transplant eligible, in fact, most of the academicians would consider transplant eligible, actually go through transplants. And it's not just about 50%, it also depends on ethnic diversity, which Joe mentioned. When you look at African Americans, only about 35% of the African Americans who are considered transplant eligible by most transplant doctors have a transplant. And if you look at Hispanics, it's down to 25 to 30% actually get referred and have a transplant. So this diversity discrepancy is a major to-do, has nothing to do with eligibility, has to do with referral patterns. So what do we want to do? So this is not, in myeloma, we don't save the best for last. You give them the best you have first, because you get more bang for the buck when you beat it up early. So you don't want to sit there and say, well, this is a good drug, I'll give it to them later. No. If it's a good drug, you give it to them now. So essentially all regimens for frontline treatment, and actually in the relapse setting too, which Joe's going to talk about, are to give 3 different classes of drugs. One is a monoclonal antibody, which he went over very briefly. Monoclonal antibodies attack a specific protein on the myeloma cell. It mentions here daratumumab. There's another monoclonal antibody called isatuximab, which has the same target. Don't want to get into that or not get into that right now. Immunomodulatory drugs, back even after I started treating myeloma, we used thalidomide. Thalidomide has a lot of problems. No one uses it almost anymore in the US. Outside the US, it's much less expensive, still used a lot in Europe and third world countries. But most people here get lenalidomide, and the subsequent relapses later on, they get pomalidomide or Pomalyst, and they get a proteasome inhibitor, which we already heard Kim talk about, Velcade or Kyprolis. One causes more potential for neuropathy, the other one causes a little more risk for cardiac problems, but everyone essentially gets one of those drug classes and the dreaded steroids. About 90% of people hate steroids, about 10% say, oh my God, it fixes all my aches and pains, I'm a fan of steroids. So we usually give 3 drugs, and that's been the standard of care. I'm going to show you data in just a little bit. The evolving standard of care is give 4 drugs: steroids, proteasome inhibitor, immunomodulatory drug, and a monoclonal antibody. Not yet FDA approved, but essentially accepted by most insurance companies and being pursued by most doctors, whether academic or private, to give 4 drugs. So in the past, there have been a lot of trials of 3 drugs versus 2, and in the frontline setting, except in very old people, which I'm not going to get into the single trial that didn't show that, 3 drugs always beats 2, and almost always 4 drugs beat 3. Again, you want to give your best up front because you want to get the most bang for the buck. So this is a trial that was done back a few years ago. It was published in 2022. It was an interesting trial of using the question here is, should you have a transplant? We're getting back to the Shakespeare, to be or not to be, to transplant or not to transplant. So there's been a number of trials to transplant or to not transplant. This is one of the premier trials. So everyone got 3 drugs, Revlimid, Velcade, Dex, for 2 to 3 cycles. Half the patients had a transplant, half the patients did not have a transplant, everyone got consolidation, which is the same regimen again, the RVD, and then they got randomized, or then they went, they went on to Revlimid maintenance therapy. So they're looking at transplant versus no transplant. The group that did not get the transplant initially was intended to get the transplant later. But let's just look at the initial data. So the line on top is the one that wins, and the line on top is the RVD plus the transplant. And when you look at the difference in 5-year remission, so when you see that on the right-hand side, I don't think I have a pointer that works. I don't know if the pointer works here. It says 5-year PFS. PFS means how long you stay in remission. So it was 56 months versus 41 months. So the group on top that had the transplant had a 14-month longer remission duration. Now, there are people, including in the myeloma field, who say, well, 14 months to go through a transplant may not be worth it, because as we see on the next slide, even though you stayed in remission longer, doesn't necessarily translate into living longer. So again, you definitely, transplant versus no transplant, every trial that's currently been completed shows that transplant patients stay in remission longer. Now, again, this trial was supposed to be comparing early to late, but only 28% of the patients in the late group actually had the transplant. And this is what I already alluded to. When they looked at the survival, the two colors are on top of each other. When they looked at the transplant, the overall survival, it was the same. Why? Because we have so many good therapies for people when their disease comes back, which Joe's going to talk about later. So do you want a longer remission? Does that give you psychological benefit to know that you're going to be in remission longer? Or you can say, I don't want to go through the 2 weeks of transplant. It's kind of a personal choice. You have to have someone that actually poses this to you in the correct fashion. And they looked at quality of life. So the red line here is the transplant group. The blue line is the non-transplant group. And yes, the transplant group has a dip in their quality of life during the acute phase of their transplant, but after they recover from the transplant, it's a wash. They essentially have the same quality of life as those patients who did not have the transplant. So yes, there's a short-term compromise for quality of life, longer remission duration, same long-term survival. Transplant's still considered to be the standard of care throughout the world. Later on, Joe's going to talk about CAR T cells. CAR T cells are being brought earlier in the treatment paradigm. I can't tell you that in the future, CAR T cells are much less acutely toxic on the organ systems. There are some late-term, as Kim's already mentioned, some late-term issues with CAR T cells that are a small percentage of patients, but currently transplant is still considered standard of care in patients who are considered transplant eligible. And this we already alluded to, triplets versus quad. So we talked about triplets are always beat doublets. This is a quadruplet versus a triplet. This trial just was completed and published. It was giving the 4 drugs. Remember, I told you an anti-CD38 monoclonal antibody. In this case, it's Darzalex or Darzalex. In this case, it was Darzalex Faspro for those that know the difference. Velcade, Revlimid, Dex. So 4 drugs versus 3 drugs. So everyone got their induction regimen for 4 cycles. Everyone in this trial got a transplant. They got 2 more cycles of the same regimen. And then they got randomized to either Darzalex Revlimid or Revlimid alone. And they had separate endpoints in the DR group. This gets complicated, and I apologize. I don't know if there's an easy way to explain this complicated schema. But if you are MRD negative, you stopped the DARA. We talked about MRD briefly. If you're MRD positive, you stayed on the doublet. So the group that was negative, they said, oh, they're in a good place. We're only going to give them Revlimid. The group that was positive, not in as good a place, and they kept them on both drugs. What they found 4 drugs beat 3 drugs. This is the likelihood of being in remission at 4 years. It was a 17% difference, likelihood of being in remission at 4 years. So 4 beat 3, just like we showed you before. And when they look at the depth of response, so this is the complete remission rate, 4-drug regimen, the one on the red is the 4-drug regimen, the likelihood of getting a complete remission, not MRD here, complete remission, 88% versus 70%. Again, the deeper the response, the better the remission duration and actually ultimately the better survival. And they look, the part on the right-hand side is called a forest plot. Not important why it's called that, but essentially it showed that every different subcategory of patients did better with 4 drugs and 3 drugs, whether you were male, female, what your age was, what your cytogenetics were. Essentially, everyone did better with 4 drugs than they did with 3 drugs. And here's the MRD data. So, and this one, let's look at the middle one, because that's the one that goes in 1 million, 1 cell in a million. And it's 65% versus 32%. It's twice as likely you're going to get MRD negative if you had 4 drugs than if you had 3 drugs. But again, because of such good therapies that we can give people when they relapse, when you look at their overall survival, it was a wash, 4 drugs versus 3. It's complicated, folks. This is a similar trial. It's 4 drugs versus 3 drugs. Instead of giving DARA, which was one of the antibodies against CD38, this is giving the competitor drug. It's called isatuximab or Sarclisa. Same basic schema as the other one, a little bit different, but the first part is 3 cycles of 4 drugs versus 3. Everyone gets a transplant. Then they get randomized to either antibody plus Revlimid or Revlimid alone, similar to what we just showed you. And then they follow these patients up. And again, when you look at, if you remember before, it was double the rate, and these don't quite compare these against trials because they're not exactly the same. But bottom line is the group that got 4 drugs had a deeper response than the patients who only got 3 drugs. And this is yet another trial, but this is 3 drugs versus 4 drugs. This is mainly a European trial. The other one was a European trial as well. So this is ISA, which is the cousin of DARA, first cousin of DARA. 4 drugs versus 3 drugs. Everyone got 4 cycles. They had a transplant. They got consolidation, 4 drugs or 3 drugs. And then they either got even further treatment with another year of 3 drugs or 4 drugs. This is a long schema, guys. And they're looking for the likelihood of being MRD negative, no evidence of disease to 1 in a million cells. And again, it's not quite as prominent a winner of 4 drugs versus 3 drugs, 67%, the one on the right-hand side, 67% versus 48%. I mean, if you looked at that first one, it was 65 versus 32. This one, not quite as much, but that was with VRD. This is with KRD. So even though 4 drugs seem to beat 3 drugs as far as reaching this MRD negativity rate, and when they look at the likelihood timeline of reaching MRD negativity with each subsequent therapy that they gave them, the initial therapy, the post-induction, post-transplant consolidation, keeps going up with additional therapy. And then when you look at the high-risk group, which was alluded to a little bit, this is a very difficult group because the response rate with patients with high-risk disease responds very comparably to patients who have standard risk. The problem with high-risk patients is they don't stay in remission as long. So this is just showing you that in this particular trial, the very high-risk group that got 4 drugs had, that's the standard philosophy is there's no difference in response rates, but when you give 4 drugs, that's not true. When they have 2 or more of those bad genetic jujus that was shown earlier by Joe, it's 77% versus 27%. So it looks like the 4 drugs does way better than 3 drugs in patients with very high-risk disease. This is very important for that 30 to 40% of patients who have high-risk myeloma. So this is a conclusion slide. I don't want to read it because I think we're already behind. So we talked about this, about MRD. I already alluded to this earlier. So if you get to this magical haven of MRD negativity of 1 cell, less than 1 cell in 1 million plasma cells, the normal cells, can you stop therapy? And the answer to that is we're not really sure yet. There are trials that are being conducted to answer that question. Can you not give a year or more of therapy if you're MRD negative? So this is a trial called the Master Trial. It's been updated. This is a 1-arm trial. There's not 2 arms in this trial. Everyone got 4 drugs for induction. Everyone had a transplant, and they were checking MRD negativity every 3 months. So they had induction, they had a transplant, they had consolidation with the 4 drugs. And if they were not MRD negative, they continued on consolidation for another 4 months. But those patients who had 2 MRD negatives, they stopped their therapies. And what it showed was, this is people who stopped their therapies after they reached MRD negativity twice. When you only had 1 or no cytogenetic badness, which is the green line, you did very well. If you only had 1 cytogenetic badness, you did pretty well, which is the yellow line. But if you had 2 or more bad jujus, you really didn't have a very good job if you stopped their treatment because they were MRD negative. Those patients, even though they're MRD negative, do not stay in remission as long because of the genetic abnormalities pushing them to a more aggressive disease state. So frontline therapy in conclusions, most places are using quadruplets of the 4 drugs that we already mentioned, either an anti-CD38 monoclonal antibody, a proteasome inhibitor, either Kyprolis or Velcade. Everyone's getting Revlimid, and everyone's getting the dreaded dexamethasone. It's not FDA approved now, but it's within the guidelines for treating patients, which I don't want to get into right now, and that's going to be the wave of the future. Now, in the future, when we have CAR T cells, when we have bispecifics, those may change this algorithm completely, that Joe's going to at least talk about how they work in the relapse setting. The data is way too immature to give you any information about using those therapies in the frontline setting, but they are being conducted right now, of including some of the therapies Joe's going to talk about in a little bit that's used in the relapse setting are all being moved earlier in the disease course, including frontline therapy. So this is a evolving treatment paradigm. Transplant is still considered standard of care. One study that I did not show you was called the Forte study. In the Forte study, they looked at KRD with a transplant, and they looked at KRD without a transplant. It was a very potent regimen, and both of them provided similar MRD at 1 year. So no transplant looked the same as far as this MRD at 1 year. However, when they looked at 2 years, the group that did not get the transplant had a significant drop-off. The MRD for the transplant group persisted longer than the group that did not get the transplant. So yes, MRD is a fantastic endpoint, but even at 1 year doesn't always predict. Just because you were MRD negative 1 year, the transplant still has an important role in the management of myeloma. Consolidation therapy, we're going to talk about maintenance therapy later, appears to help in a lot of the patients, particularly those with high standard risk disease. And in the future, instead of saying you have to be on something forever, which we'll talk about in the maintenance therapy talk, if we can use MRD to guide our treatment algorithm so we can stop the therapy when you become MRD for a certain period of time, then you're off drugs. And who can complain about being off of therapy? These are the guidelines that are published by a group of, I think it's 21 institutions, where they all get together and they come up with recommendations for treatment regimens that may not be within the FDA approval, but most insurance companies, including Medicare, follow these guidelines. And then how do we decide who's eligible for transplant? So first of all, you have to have a doctor who refers. Again, a lot of the doctors don't refer. There's reasons for that. But you have to be referred to a transplant center to see if you're transplant eligible. Most centers in the US will transplant patients that do not have significant comorbidities up to the age of 75. I already told you, our group's transplant happy. We actually transplant patients in reasonable physiologic condition up to age 80. And I showed you that transplant versus no transplant still shows an advantage for remission duration for those who had a transplant. And if you look at the bottom, the article that's referenced here, oh my God, Dr. McHale is the senior author on this, or the first author on this paper. What I'm saying must be true then, because it's got his name on it. So there are different ways to determine if someone's transplant eligible. There's a frailty index, which most doctors can tell if a patient's sick or not when they walk in the clinic. You don't have to really plug their numbers into a formula to figure out if you think they're frail or not. Most of us have really kind of an eye for that after a period of time. Maybe those fresh out of their training, but most of us can actually tell. But it's based on their age, how they function with their daily activities. You know, if they have heart problems, kidney problems, lung problems, and then there's indices that can tell you how frail they are. And patients who are frail don't do as well as patients who are not frail. No brainer. So these are guidelines for patients who are not eligible for transplant. The current standard of care in the US is one of two regimens. I personally think there's only one option here, but it's giving the anti-CD38 monoclonal antibody, DARA, or probably in the future, isatuximab, with Revdex, which is DRD. A lot of doctors are still using Velcade Revdex. I will tell you, when you try to compare across trials, which is not a very kosher thing to do, that it looks like, if you look back historically, that the DRD is far superior to the VRD, and you don't have to worry about neuropathy, which still occurs. And it was mentioned by Kim, you can have neuropathy from Velcade, still occurs even if you give it once a week. It's still 20 to 25%. But be that as it may, these are some of the regimens that are recommended for patients who are not transplant candidates. And this, what I came up with for, I told you DRD is kind of the standard of care. This was one of the trials I alluded to earlier, 3 drugs versus 2 drugs. So DRD versus RD. And when you look at the study, over 40% of the patients in this trial were over the age of 75, which were outside the US is absolutely not an indication for transplant. And when you look at the response rates, 3 drugs, which is purple, beats 2 drugs, which is orange. And the depth of response as far as getting complete remissions, 30% versus 13. And when you look at how long they stay in remission, 52% versus 29%. So there's little doubt that 3 drugs beats 2 drugs. As a historical perspective, there was a trial called the SWOG 0777 trial that was led by Dr. Brian Dury, who used to be the chair for the IMF. Quite a while ago, they conducted this study and they looked at VRD versus RD. The likelihood of the median duration of remission in that trial was 41 months. The median duration in this trial of staying in remission is 63 months. So to me, there's no brainer that DRD is superior to VRD without a lot of extra toxicities. In this particular trial, the overall survival was superior with 3 drugs versus 2 drugs. And this is just rehashing what I already have covered with you. So I think, is that it? So Joe already showed you this. So back in the day, we didn't have any of these words on here. I mean, there was none. You had frontline therapy. There were only two frontline therapies, and there was transplant back in 1990. When I first started doing, there was two different regimens. One was called MP, the other was called VAD, and there was transplant, and that was it. There was none of these other alphabets on here. And again, I thank the sponsors for the opportunity to speak to you all. I'll turn it back to whomever.
Well, Dr. Wiesel and Kim and Dr. Joe, you are just all amazing. I'll call you myeloma mentors. We learn so much from you, and you have the ability to paint a picture no matter what stage we're at. If we're newly diagnosed and trying to digest what is myeloma, the language of myeloma, you really do help us to navigate through and understand so we can have these better conversations and questions with our doctor. So thank you all for being so gracious with your time. And speaking of time, I would like to just make a little adjustment here. So we do have the important time to take the questions that have been coming in from all of you. If you haven't submitted a question, please feel free to do so in the chat box, and we will be getting to them. We're gonna move our break to about 1/4 past the hour, whatever time zone you're in. So 1/4 past the hour until about 1/2 past the hour will be our break. So we have a good time to address the questions. And so Dr. Joe, would you like to start us off?
Sure, absolutely. Well, first of all, let me again just thank Kim and David for just incredible lectures, so clear, so thoughtful. I know it's a little bit of an information overload if you're sitting there with your bottle of water, glass of wine, and listening, but I do hope that this is really helpful to you. So as Robin just mentioned, we're going to take about 13 minutes. And we have about 37 questions. So we're not going to be able to get all the questions, but what I'm going to hope and do is almost take us to the rapid fire round here and answer questions quite quickly. I'm going to answer several of them, but I'm going to pepper them with the lovely voices of Kim and David in between so that you can hear in advance. So hear everybody answer some of these questions. So I'll just quickly mention them and then we'll answer them. So question one is, if your kappa free light chain and lambda free light chain both went up a bit out of the normal range, but your ratio of the two is normal, does this mean you're coming out of remission, basically, is what the question is, or is there another reason for it? The short answer is this is not an indication of remission. So part of myeloma is that it's either kappa or lambda, one dominates. When they both go up, it usually means that the kidneys aren't clearing them out, so someone might be dehydrated or have kidney issues, or may even have an infection, and our good antibodies get pushed up. So thankfully, that's not as concerning. Is it common to have symptoms even in remission on Revlimid post-transplant, leg weakness, hip pain, neuropathy? Obviously, it's a little bit difficult to answer that question without more detail, but yes, remission doesn't necessarily mean that there's absolutely no symptom, typically not from so-called active disease, but residual. So sometimes people have neuropathy, as Kim mentioned, from treatment that may be carrying on there afterwards. But we do have to sometimes distinguish that from Revlimid itself, even though we don't think of Revlimid causing neuropathy, even though more often than not we chose Revlimid as a maintenance therapy that you're going to hear from Dr. Wiesel a little bit later, because it's not very, it's usually generally easy to take. There are key symptoms like fatigue, like diarrhea, like skin rash, like infections that people can have. I understand the genes with translocation, but I have 1q gain. What does that mean? This is a relatively new genetic phenomenon that we're understanding better. Every chromosome has what we call a P arm and a Q arm. That's where we get the expression, mind your P's and Q's. There's your useless trivia for the day. But if we have learned that if there are extra copies of 1q, if there are at least 3 instead of the 2 normal, or even more so if there's 4 or more, then that classically indicates a so-called higher risk myeloma. And I'll come back to the issue of high risk myeloma in just a minute. All right, I'll do a couple more and then I got to give some to Kim and Dave here. So if a patient is in remission, MRD negative, then has a relapse, can the genetics of the disease change? For example, at diagnosis, they have lambda light chain. Can it become kappa or another type of myeloma? So two ways to answer this. One, generally not. We don't see very often this so-called class switch from kappa to lambda, from IgG to IgA. It's not unheard of. We actually probably believe what really happened was that at the start there were two clones to begin with, and one was more dominant than the other. But that being said, people can develop changes in those genetics and develop high-risk disease when they're not initially high-risk disease. So if someone, and this is going to answer a question that comes later, if someone is standard risk, they can become high risk. Once someone is high risk, we pretty much consider them always to be high risk. They typically do not move down to slow risk, to lower risk. And that's what answers question 5. Question 6 is, are there available slides at the end of the webinar? The answer is absolutely yes. We will share those with you, and Robin will share how to do that. So here's a question for Kim. Is there any treatment for low IgM, like giving IVIG for low IgG?
Love this question. And so we usually give IVIG for a low IgG, but as I said, I think earlier, it doesn't necessarily have to be a low IgG. But if you present with a lot of infections, we need immunoglobulin G to fight bacterial infections. And this is usually what we do. Is there anything we can do for low IgM? We just monitor that very closely, but really isn't a lot unless Dr. McHale or Dr. Vessel, if there's something that you do in your centers for low IgM.
Typically not. It's really the IgG that's the most important to protect against infection. I don't know, Dave, if you do anything there.
No, we don't do anything different. And I don't think there's any. There are, different products of IgG, but as far as I know, there aren't any IgA or IgM gamma globulin products available that I'm aware of.
Correct. That is correct. Okay, so here's a good one for 2 questions for you, Professor Wiesel. Diagnosed in April 22, had my transplant in August of 22. On initial maintenance therapy, and I know you haven't given the maintenance therapy talk, but this is okay, since January 23. Since my M spike has been around 0.25 since the transplant, I take lenalidomide plus Faspro, though I am not high-risk cytogenetics. Would you agree adding Faspro is a reasonable approach?
So I'm a little confused if the individual was on lenalidomide and then because they didn't go to 0, they had the Faspro, the Darzalex, daratumumab, or they started on both.
I'm going to assume they started on both and their M spike is stuck around 0.2.
Yeah. I'm surprised it didn't get better. It depends if they were on the Dara before. It would depend if they're on Dara before. Otherwise, I would expect a deeper response. So right now, that combination is not FDA approved. It's not even in the NCCN guidelines yet to give the doublet. But based on that Perseus trial that I showed you of DR versus R, the DR beat R, it's probably soon going to be FDA approved to give that doublet for maintenance therapy. But again, getting back to a scenario I posed before, I don't know, and I don't know if my colleagues know, that if someone has got a small protein left, should we add a 3rd drug to that to try to beat them into remission just to get to that magical MRD? And no one has an answer to that at this point in time. So I probably would agree with that, what the individual's on. I would not add another drug, and I would just sit tight.
I completely agree. I think paradoxically, we have some patients that never get into MRD negativity, always have that little schmutz of protein left that actually do very well. And there's some of the work from your former colleagues in Arkansas that demonstrated that. The other point I might make here, it's possible that residual M spike of around
could be the Dara, correct?
Faspro itself. This is the paradox of myeloma. I was explaining this today in clinic to a medical student who joined me for her first day ever in myeloma clinic. And I explained to her the paradox is here. We treat a monoclonal protein disorder with a monoclonal protein drug. and so sometimes, believe it or not, the drug itself, Darzalex, as we can see with isatuximab or Sarclisa, the same thing, that there can be a little bit of M spike. All right, I think we still have time for a few more questions, Robin. So I'm going to ask, I'm asking Dr. Wiesel the tough ones. My husband had CAR T in October and his M spike just went to 0. It's wonderful to hear, by the way. We're thankful to hear that. He has a 17p deletion. How long before he may start to relapse?
It's a great question. I don't know if Joe has an answer to that one. Again, the response rate in general to CAR T cell, I'm assuming that there's percent cilta-cel Carvykti. It's 90 for those who actually get treated. It's almost 100%. It's 99%. So I don't think we have enough mature data yet from the trials of CARTITUDE-1 versus CARTITUDE-4 to cull out the patients with the 17p specifically, just to give you a figure of how long it would last. I can tell you that if this individual had 4 or more lines of therapy, which was the original indication up until exactly a month ago, the average time people stayed in remission is about 37 months. I cannot tell you specifically on any individual how they're going to do.
Yeah, I think that's actually a perfect way to answer it, David, because I think we want to be clear. Of course, we can't give advice to one specific person. It's hard in this context, but to know that myeloma is highly variable. When we talk about those curves that Dr. Wiesel showed of so-called progression-free survival, we talk about the median, or basically the average time. So if the progression-free survival is, let's say, 24 months, it just means that half the people relapsed before 24 months and half the people relapsed after that. So it's giving you a rough guide, right? You might have the average time it takes you to drive to your favorite store. Some days it can be longer, sometimes it can be shorter. So it's not always a perfect measure, especially as the disease is so variable. I think we'll do 2 more here if we can, Robin. One is someone from here in Scottsdale. Thank you for your commentary on my mountain analogy. I love it. It looks like this patient got KRD, had a transplant, and is now getting clonoSEQ every 6 months. I know who your doctor is based on doing this. And, Phoenix, they do a great job there. The person's on Revlimid and daratumumab. And the question is, there's still some MRD positivity, although as we've just explained, that doesn't necessarily mean that you need to change treatment. How long do you typically give maintenance therapy? And I know, David, you'll answer this in your next talk, but
I am going to answer this.
Okay, let's save that for your next talk. And I think that would be really good. I'll ask Kim this question: where can I find recommendations for immunizations?
So what we do is we work with our infectious disease group. You can also look at the CDC website, certainly, and you can look on the IMF website. It's all there, and just keep going. And sometimes these recommendations vary a little bit, and so get some more information. I've had patients that have received their transplant vaccinations at other places, received different vaccinations, and then came here because they've relocated. So it can get a little tricky. But I think it's just important to follow the guidelines of where you were transplanted.
Absolutely. Great point. And when in doubt, go to myeloma.org. And maybe the last question as we go to our break, Robin, what impact does alcohol consumption have on the medications? 1 drink per day or 1 drink per week? And this is a tough question. It gets asked a lot. I don't think we actually have a perfect answer. There may be very specific times in your myeloma treatment, and particularly around transplant, where we really might encourage our patients not to have any alcohol. But in general, we balance that with, as I say all the time, I don't treat myeloma. I treat people, and we want people to enjoy their lives and be responsible. And most recommendations, whether it's from the Liver Society, from the Cardiac Society, and others, I generally go by the so-called 2 rule, which is you shouldn't have more than 2 drinks in a setting, and you should have at least 2 dry days a week. That keeps you below 10 a week. There's different data supporting and refuting that kind of approach, but that's generally how I try to approach it, to keep things in moderation and to match that with very good hydration, because of the comments we made earlier about kidney function. But with that, I'm going to turn it to you, Robin, to tell us when to come back after people can get up and get a stretch break, so we don't have any DVTs during this workshop.
Well, the three of you did a fantastic job, not only in answering the questions, but we are exactly at 1:15. So bravo to the three of you. And just to let everyone know, when you come back, please be back at 1:30, and we will go over maintenance with Dr. Wiesel, and then relapse and clinical trials with Dr. Joe. And we'll wrap up with plenty of time for final questions. Maybe it won't be such a rapid fire. And the last thing I'll share with you is that, yes, not only will these slides be available, but the entire replay will be available on the IMF website, and it will also be sent to you in an email because you have registered for this program.
Yeah, I'm seeing, sure, thank you, Robin. I'm seeing a lot of questions about maintenance therapy and about the number of cycles for induction therapy. A lot of this is controversial. The maintenance therapy is not as controversial, but let's cover some of that. So maintenance therapy is intended to keep you where you're at the minimum is to keep the disease under control, and at the maximum is to get a better response. So why think about maintenance therapy? Why do myeloma patients stay on treatment? So the example I use for my patients of why we keep them on therapy, whether it's maintenance therapy or in the relapse setting, is the following little scenario. Think of your new car. You just bought yourself a new Mustang EV car, nice hot red Mustang EV car sitting on a hill. So how do you prevent the car from rolling down the hill? Is you put your foot on the brake, right? Because you don't want to crash your new car. But what if you let your foot off the brake? The car starts rolling down the hill. So the whole idea with maintenance therapy is to keep your foot on the brake so the car doesn't roll down the hill. Now, the problem with keeping your foot on the brake in reality, and as far as the analogy I'm using, is if you keep your foot on the brake long enough, the brakes wear out. And you have to have new brakes, i.e., you need to come up with a different therapy to put the brakes on. So the previous concept, not counting MRD, which we just talked about, was you have to keep your foot on the brake to keep the disease under control, or the car rolls down the hill and crashes. So that's the background of maintenance therapy. So, and I already talked about this. The issue with maintenance therapy is you want to have something people can tolerate. And yes, long-term Revlimid can affect your blood counts. Long-term Revlimid can cause diarrhea. Long-term Revlimid can cause fatigue. Long-term Revlimid in the setting of after transplant can increase the risk of getting a second cancer by 3 to 5%. There's no free lunches. So there are potential side effects to keep your foot on the brake, to keep that remission longer. It's not without a cost. So this is a very complicated slide. And I'm just going to summarize it without, I want you to even look at the slide. But a meta-analysis is when you take multiple trials and you throw all the numbers in one, sort of like taking a big cauldron, you know, the witch's cauldron, and you throw a bunch of stuff and you brew stuff up, you stir it around, and at the end you come out with some kind of soup out of the witch's cauldron. So they took 3 different trials, they threw everything into the witch's cauldron, and they wanted to find out what came out of it. And when they did that, looking at these 3 trials, all compared maintenance with no maintenance. So all 3 trials, either yes or no. And when they threw everything into the pot, they said, yes, maintenance therapy improved how long you stayed in remission, and yes, maintenance therapy in this analysis improved your survival. The problem I have with that whole concept in this thing is it's a lot of number crunching, and it's not what happens in real life, because only 2 of the 3 trials actually showed a survival benefit. So bottom line is, all the trials show you improve how long you stay in remission. Whether you live longer or not, I think it's controversial. And that's what, this is just another example of the same information. This is throwing all the numbers into the pot, you pull it out, and when you pull it out, the blue line says that you survive longer, if you had maintenance therapy versus just being observed. And I mentioned this just a little while ago, the combination of transplant, which uses a drug called melphalan, which if someone's interested, I can go over the history of how melphalan was developed, but I will tell you that it was actually derived from mustard gas. And kid you not, that's where it was originally derived from, is mustard gas. And when you combine transplant with melphalan, you give Revlimid after a transplant, there's about a 3 to 5% chance that you're going to get a second malignancy. It could be another blood cancer, it could be a solid colon cancer, or lung cancer. So there is a slight risk of getting a second cancer if you have lenalidomide after transplant. So the question you have that you have to answer for yourself is that 3 to 5% risk worth staying in remission for an average time, which we're going to see in a little bit, which is about 2 years. So are you willing to take that 3 to 5% risk to stay in remission about 2 years longer? Individual choice. Doctor should pose this to you. And this is just going over some of the same data, was putting all the trials into the witch's pot. So this is a trial, myeloma 11 it's called the MRC 11, was done in the UK. Very large trial, 1,500 patients. Half the patients got Revlimid, half the patients were observed. So another trial was not included in the witch's pot. This is a separate trial. It's actually the largest trial of yes or no Revlimid maintenance. And what they found, the line on top wins, and I just told you it's about 2 years. In this trial, it was 18 months. Some of the other trials indicate the remission duration is about 2 years longer. One of the determination trial was 2 years, and the CLGB trial was 2 years. So it's 18 months to 2 years longer remission if you go on maintenance therapy. And then the next question was also asked in this trial, and people say, and some of the questions are, how long should I stay on maintenance therapy? And the answer gets back to the Mustang, the hot red Mustang on the hill with the brake. So they actually looked at the duration of remission of the patients on that trial. They looked at those patients who were on 2 years and stopped, 3 years and stopped, 4 years and stopped, and 5 years and stopped. And what they found is the patients who stayed on continuously for 5 years and beyond had the longest remission duration, i.e. don't stop the Revlimid ever. And the catch to that is we don't know what MRD plays into that scenario I just posed to you. That could change that treatment paradigm, but for right now, once you start maintenance therapy, based on these other trials, you should stay on it. In a second, we're going to show you an analysis, I think it's in the slide deck, of a US trial versus a French trial. In the French trial, the patients only had 1 year maintenance. In the US trial, they had over 3 years of maintenance. Which one won? Same exact trial, 1 year versus over 3 years. The US trial, when they stayed on longer, had a 2 year longer remission duration compared to the French trial when they stopped at 1 year. So the answer is yes, maintenance keeps your remission longer, and you should stay on it. So, but, you know, maintenance, we've been doing these trials with maintenance therapy for 15 years. Can we build a better mousetrap? Can we make it something better? And there's a couple trials, which I already alluded to, of more than one drug for maintenance. Now, I talked about this trial a little while ago. I didn't have the schema up. I told you that in this trial, if you look at the blue box and you look at, I'm trying to make sure I got the right one, the blue box, and you look at the green box, forget the yellow box, it lost. So if you look at the blue box, that's a group that got KRD, Kyprolis Rev Dex, transplant. The green box are the group that had KRD, no transplant. I mentioned to you earlier that the MRD at 1 year was the same between those two, but at 2 years, the blue box wins. Well, there was a second part of the trial besides blue box versus green box, and then it's yellow versus purple, or whatever color that is. So the patients who finished Their consolidation therapy were randomized either to one drug, Revlimid, or two drugs, Kyprolis and Revlimid. And as I mentioned earlier, two drugs beats one drug. Or three drugs beats two. Most trials show four drugs beats three. Well, in this particular trial, two drugs for maintenance therapy did better than one drug. Right-hand side shows this. The purple line is the two drugs. The orange line is the one drug. So KR did better than R. Two drugs did better than one drug. In this particular trial, they stayed on it for 18 to 24 months. Then they looked in the same trial, what about the people that have high risk? And there's a number of questions about high risk. So standard risk, no bad genetic juju. High risk is generally, we'll just say that's only one adverse genetic feature. Double hit means you have two or more bad genetic features. And when you look across the board, the blue line on the top beats the orange line. So two drugs beats one drug for all groups, whether you're standard risk or various levels of high risk. So two drugs beat one drug. I personally treat my high-risk patients with a two-drug regimen for maintenance therapy, not one drug. I don't give them Revlimid for the reasons shown in this trial, and this is the basis for me doing that. So there have been trials as well, and some of you may have been on Revlimid and Velcade. You know, when they looked at the Velcade Revlimid, I don't use it because I don't like Velcade. Again, we talked about before, it can cause peripheral neuropathy. I'm not convinced the data is that convincing that two drugs is better than one drug when you include the side effect profile. There has been a trial of Revlimid and Exasmid or Ninlaro that showed slight benefit of two drugs versus one drug. And we showed you before in that Perseus trial, we're going to talk about again, of giving Revlimid with Darzalex. And there are two trials. I just mentioned the one on the bottom bullet, where they gave Dara and Rev versus Rev alone, and the group that got Dara and Rev did better than the Rev alone. And there's another trial which really is very confusing, and even amongst myeloma doctors, they don't always quite grasp the concept of this trial called the Cassiopeia trial. It's kind of complicated. I'll try to walk you through it. I don't want to spend a whole lot of time on it. But bottom line is they gave two different cocktails, three drugs, a three-drug regimen or a four-drug regimen. The four-drug regimen had daratumumab in it. The three-drug regimen did not. And they went through initial therapy. They had a transplant. They got consolidation, either three drugs or four drugs. And then they got randomized to observation or to Dara alone every 2 months. And the group that got Dara alone, if you never had Dara before, still did as well as the group that got Dara the whole time. My interpretation is that is you can hold Dara off till later because you can always give it to the patients later. Can't speak for Joe's take on that trial. There's no doubt that Dara is a very valuable drug. I'm not sure that we need to give it up front in the four-drug regimen. I think you can safely give it either as maintenance therapy or salvage therapy. Very controversial, even in the myeloma experts. But bottom line is, Dara can be used for maintenance therapy. It's an effective drug, and you give it with either by itself or you give it with Revlimid. This rehashes the second bullet, which we just alluded to and shows you the schema before. 4 drugs versus 3 drugs. Then the patients after the transplant got randomized to 2 drugs versus 1 drug. And the 2 drugs won the race. How long? We've already mentioned that. This is the same data I just mentioned to you about the MRC-11 trial. It was random, a very large trial of Revlimid versus observation. And then they looked at different time points, 2, 3, 4, and 5 years. And the group that had 5 years, shown here, had the longest remission duration that they shouldn't stop the drug. So in conclusion, I think this is it. For staying remission, should be on at least 4 to 5 years. A lot of the private doctors say, oh, you've got a great response, we'll stop you at 6 months. Not the idea that should be used. Got to keep your foot on that brake. It keeps the myeloma cells asleep longer. We don't know about the patients who are MRD negative. Going back to that trial in my initial presentation, the master trial, where if you were MRD negative twice, and then you stopped drug, you had a very good outcome, except for those patients who had high-risk disease. The ones, otherwise you should stay on therapy. MRD positive, she should stay on the Revlimid no matter what. Only the ones that are MRD negative could be considered based on that trial. It's not a very large trial. It's being reproduced in much larger studies. This is one of the hot topics everywhere in myeloma, is how we utilize MRD to manage our treatment paradigm for our myeloma patients. Yeah, I don't want to talk about that. Questions: should post-transplant maintenance be recommended for all patients? You know, that's a great question. If you're MRD negative, I don't know that answer should be yes anymore. I'm not sure what Joe's opinion is on that. But if you were MRD negative before transplant, MRD after transplant, or MRD negative if you went on consolidation, I don't know you need maintenance in the standard risk patients. Different question. What agent? Revlimid is considered standard of care everywhere in the world. I already told you daratumumab will soon be approved. A lot of patients, and some of the questions are already referring to that. A lot of the patients are already getting a doublet, and that's based on that Perseus trial. So it will end up being FDA approved to be used as a doublet for maintenance. It's not approved at that point, but you probably get it covered by insurance. How long? Until progression. Keep your foot on that brake. High-risk site genetics, I personally give Revlimid and Kyprolis. We don't have data yet from that Perseus trial regarding daratumumab and Revlimid. That data is, I'm sure, out there, but I'm not aware of it yet. Maybe Joe is aware of that data, but right now I would give all my high-risk patients a doublet, and I would keep them on it. And whether that doublet's going to end up being Revlimid and Kyprolis or Velcade, or whether it's going to be Revlimid and daratumumab, I'm sure there's studies being conducted to answer that question. What do we do about MRD and maintenance therapy? I posed a couple scenarios. It's still considered investigational. It's still being looked at in clinical trials. Second primary malignancies, again, they're in the 3 to 5% range. They're real, and then you have to decide the risk-benefit ratio, and if that's what's the right pathway for the individual patient. And I shall finish there.
Wonderful. Well, thanks so much, David. As you can see, sometimes we end up asking more questions than we can answer, but that's good, right? That tells us that we're pushing the limits and thinking through this. I sometimes joke and say, I put 10 myeloma doctors in a room and I have 15 opinions, right? So even within us, there's lots of choice. I'm also noting, Robin, that we have up to 66 questions now. So just realistically, we won't get to them all. I'll keep my talk a bit shorter, so we have some time for Q&A at the end. But I think it's motivating us, Rob, and I'll put a shameless plug in for our Facebook Live events, that we sometimes do a Facebook Live called Ask Dr. Joe Anything. We will definitely have to have more of those in the near future, because it's going to be impossible to get to all 66 questions. So we did say that, sadly, despite these huge advances, despite the great work that Dr. Wiesel shared with us with frontline therapy and maintenance, despite what Kim shared with us, that we care for patients in a supportive manner throughout their whole journey, this disease, sadly, at some point does come back. And so we're going to talk just a little bit about how we approach relapse disease. I mean, it's impossible to cover all these topics in great detail, but we're trying to give you a sense of how we think about it. I say this to my patients all the time. I don't have all the answers, but I can share with you how I'm thinking about we approach this so that we can come up with a decision together. And this is a beautiful model of shared decision-making, where we really do have More options than we ever had before. Granted, I'll give Dr. Wiesel that he did start in myeloma before I did, when he talked about what it was like back in the 90s. But we have now more choice than we've ever had before, and we'll talk a little bit about all these different choices. One of the principles we've already shared is, unfortunately, with each relapse, we do see fewer patients eligible for treatment, and sometimes people just have to stop treatment. Sadly, some people die. So we don't get into this thinking, and Dr. Wiesel always shared this with us, we don't save the best for last. I say it all the time, saving the best for last is great for a Hallmark movie, but not for myeloma. And so what we do early on really does make a difference, and that's why we typically think about how we treat myeloma. I've talked about frontline therapy, now we talk about relapse. It's not a perfect division, but we sometimes call it early relapse and late relapse, meaning when people have only had 1 or 2 or maybe 3 lines of therapy, and if they've had multiple lines of therapy. And a couple of principles that will guide us. One, as we've heard many times, depth of response matters. So we want to get a deep remission, and generally speaking, MRD negativity, although we've already shared that that's not always the case. Number 2, we have to respect high-risk disease. One question asked, what's the difference between high-risk and aggressive? They're pretty much thought of the same thing. Sometimes we can identify high-risk in someone with cytogenetics. Sometimes we don't see any high-risk cytogenetics, but the disease still behaves aggressively. It relapses soon after transplant or relapses very quickly and aggressively. We want to balance efficacy and toxicity, and Kim talked to this about this very nicely, that we don't just say you'll take it and you'll like it. That's not how we approach myeloma. And we have to realize that as we start talking about people being on treatments for long periods of time, our approach to toxicity or their tolerability or their quality of life is so important. It's one thing when you go see Dr. Wiesel and he says, look, we're going to go through this transplant. It's not going to be the best month of your life. We're going to have some challenges, but we're going to get through it. And then you'll be out of the transplant process. If I say that, you're going to be on this treatment for 3 years and you're going to struggle all 3 years, that's different. We want to make sure that we balance that. And then, as we've learned, myeloma is smart. It figures out how to grow despite the treatment that's been given. And so very often we have to come at it in a different way. And so we use this expression of using a new mechanism of action or a different way to approach myeloma. And I'll share some of those different ways here tonight. Now, someone asked in one of the questions, I'm trying to answer some of the questions even in my talk, Robin, how do you define refractory? So when we say relapse means someone's had the disease, they've gone into some kind of response and it's come back. Refractory means that you've been on that drug or that strategy and the disease has grown either on it or soon thereafter. And so when we talk about these different therapies, we'll be talking about this concept of relapse, refractory, or progression. And then importantly, we talk about lines of therapy because sometimes the FDA says you can only use a drug after 2 lines or 3 lines or 4 lines or 5 lines. 1 line of therapy basically is when you're given a treatment until the disease wakes up again. So if you heard what Dr. Wiesel shared about maybe someone getting DVRD, then a transplant, then Revlimid maintenance, that whole thing is 1 line until the disease wakes up thereafter. Again, we have all these different guidelines. I'm not going to read them. This is just basically a list of what we're able to use. It's a bit of an alphabet soup of all these different treatments. And the list goes on and the list goes on. And so we decide basically then with this sometimes I've called it the Cheesecake Factory menu of choice, because if you've ever gone to the Cheesecake Factory, and I have no shares in the Cheesecake Factory, there's no conflict here, but it's like you need a table of contents. There's way too many choices. You have like 30 pages of choices. Like, just tell me what you recommend and I'll eat it. We have all this choice in myeloma. How do we make the decision? How do you make a decision on what you eat that night, right? Wow, what did I have earlier today? What do I feel like tonight? And so here we have 3 categories. The disease itself, is it high risk versus standard risk? Is it growing very quickly or not? The treatment or therapy-related things, what have they had before? What have they been refractory to before? How did it go before? And then the patient, of course, at the very center. Do they have certain signs and symptoms? Do they have neuropathy? Do they have diabetes? Do they have these other things that may influence our choice? And that's because myeloma is not the same disease. Some people get treatment, they go into a long remission, Other people, most people are kind of like this blue line, that the disease comes back at different points. And sadly, with each relapse, the time intermission is shorter. But we also respect the fact that there are some patients like this red line where, unfortunately, disease comes back quite quickly and can be very aggressive. And so it's not really one disease. In the early relapse setting, and there's by no means I'm going to go through all of this, we have all of these drug combinations. Because historically, people didn't get a lot of daratumumab, Darzalex, or isatuximab Sarclisa in frontline setting. We use a lot of it in the early relapse setting. And so those combinations have really been at the forefront of early relapse. But as of just over a month ago, I mean, this just in terms of news, as of April the 5th, the FDA has now allowed us to give CAR T-cell therapy earlier, and I'll talk a little bit more about that as we go through. So if we go back to what we published a couple of years ago through the International Myeloma Working Group, we divided people. Are you refractory or not refractory to lenalidomide? Meaning, when your disease relapses, are you on lenalidomide maintenance? And if you are, then you're refractory to lenalidomide, and we give you combinations that usually involve either pomalidomide or carfilzomib. But if you've not been refractory to lenalidomide, then we'll give you something that has lenalidomide in it. But then as we start to get later, it gets a little bit more complicated. So this is from my colleagues and my former colleagues when I used to work at Mayo Clinic. We created this thing called MSMART, which is a way of approaching a kind of a guideline therapy for patients. And so again, we look and say, are you refractory or not refractory to something? Because if your disease wakes up while you're on a certain drug, generally speaking, we stop that drug because it's already proven that it can't keep the disease down. And so we go to different combinations. And again, the point of this slide is not to go through it all, but just to show you all these different letters and all these different things that we have. But now what is very much going to change is with CAR T-cell therapy coming into early relapse, and I'll discuss that a little bit more. So we have all these different drugs. The drugs that we've talked about before. One question said, what's the difference between Velcade IV and giving it subcutaneously? We have seen less neuropathy when it's given subcutaneously. We've seen less neuropathy when we give it once weekly. I say this all the time. There's no drug that we use now in myeloma that we use the way we first gave it. 20 years ago, Dr. Wiesel and I were giving thalidomide 800 milligrams. Now we hardly ever use it, but when it does get used, it's used at a lower dose. We used to give Velcade, Kyprolis, and Expovio or selinexor twice weekly. Now we pretty much give it once weekly. So there are different ways to use these drugs together, and we try to do so in a way that is best for the patient. And so now with these newer drugs that have come in with the monoclonal antibodies that we've talked about, Darzalex, Simplicity, and Sarclisa, we have more options. But now more recently, we have these new fancy schmancy kind of approaches that I'm going to describe shortly, these ones that really engage our immune system. And I'll talk about what are these BCMA strategies. So BCMA stands for something on the surface of a myeloma cell called B-cell maturation antigen. And we have lots of different approaches to use those. And the guidelines have guided us through that. So what are these newer therapies after someone has typically had the so-called triple class refractory, or you've had a monoclonal antibody, you've had a proteasome inhibitor, you've had a immunomodulatory drug, and typically at least two of those last two classes? We have a few choices. One drug is selinexor, which we used to give twice weekly by itself. Now we typically give it once weekly in combination. And then we really have two new approaches. One is CAR T-cell therapy, and one is bispecific antibodies. I've crossed out the drug here called antibody-drug conjugate, belantamab or Blenrep, because it was removed from the U.S. market. Although based on data that's going to be presented next week in Chicago at our annual cancer meeting, we actually believe there's a very good chance this drug will come back very soon. That's why I didn't eliminate it from the table. I wanted to keep it there. When it comes to CAR T-cell therapy, we have two drugs. One's called Abecma, one's called Carvykti. When it comes to bispecific antibodies, we have three drugs that are Tecvayli, talquetamab, and elranatamab, and more of that as we go through here. And just to give you a sense that those aren't the only things, I'll talk about the bispecific antibodies. We do have some other interesting drugs coming. There's a group of drugs called cell mods that are kind of like the next generation of drugs like Revlimid and Pomalyst, the immunomodulatory drugs. They work in a similar way, but not exactly, which is why they're kind of thought of as a separate class. And there's two drugs there. One's called iberdomide and one's called mezigdomide. I don't make the names, okay? I know it's hard to keep track of them all. And then there are other small molecules we don't really have time to get into tonight. But I really do want to spend time on CAR T and bispecifics. I think those are the ones that are the most important. So how do I summarize CAR T quickly? Lots of fancy pictures here. Let me make it simple. You have white cells that live in your body. They're called T cells. They're called T because they were first created in your thymus. We also have what are called B cells that originate in our bone marrow. That's where they get their letter. And I want you to think of these T cells like soldiers that have the capacity to be trained. And basically, we take T cells out of you. For those of you who've been through a stem cell transplant, you know what it's like to have your stem cells collected. It's a similar kind of process. We collect these T cells, and then we put them through a very fancy manufacturing process where basically we want these T cells to have a receptor on the outside of them that is desirous to find myeloma cells. That's going to hone in on a myeloma cell. And that's why it's called CAR. The CAR stands for chimeric antigen receptor. Antigen is just a fancy way of saying something that sticks out of the surface of the myeloma cell. And so what we do is we play with these T cells to make sure that they are basically trained to look for a patient's myeloma. They do so by looking for that BCMA that's on the outside of the myeloma cell. And we can actually multiply them in the lab. We give them to a patient, and they also multiply in the patient as well. And it's remarkable. It's by far the most active therapy we have had in the history of myeloma by itself. It comes with challenges that I'll share with us in a moment. But then, as I say, they're given back to the patient. And now these amped up Rambo-like T cells are just looking for myeloma. Let's find a way to get these myeloma cells taken down. So for the patient, you go through that apheresis where your T cells are collected. They go off for manufacturing. Sometimes during that manufacturing period, and we're learning about this, it may be important for patients to actually get what we call bridging therapy, to push the disease down even further while you wait for those cells to come back to you. A few days before the cells come back to you, we give you some chemotherapy to kind of calm your immune system down and tell the T cells that are left, hey, don't get too excited when these other soldiers come to the battle. And then we give the infusion and we follow patients very closely there afterwards. And when we started using this drug, these two drugs, both Abecma and Carvykti, I mean, even us kind of geeky hematologists were getting excited because we'd never seen response rates of 70, 80, 90% before in patients that have been so heavily treated. But patients in both of these trials, on average, had 6 lines of therapy. And here we're seeing over 3/4, if not almost all patients having a response, which was really, again, jaw-dropping and important. And that being said, every drug comes with a risk, and I don't want to make it sound like it's completely perfect. There are challenges with it. I don't have time to go into a lot of detail. Kim beautifully described some of this earlier, but there's sort of 4 things we often think of when it comes to CAR T. One is this thing called cytokine release syndrome, where the immune system gets kind of shocked by all these soldier cells that have been infused back into the system. Number 2 is people can develop so-called neurotoxicity. It can be short-term, but sometimes it can be long-term. And there are a few situations where we have to look for even people having very severe late-term side effects, neurotoxicity. Cytopenias or low blood counts, just like we do with transplant. As people get treated, their blood counts will drop. And then we've learned that because we're quite heavily suppressing the immune system, people can get infections. And each of these have to be managed and as much as possible prevented so that patients don't suffer from them. That's the rapid fire overview of CAR T. I mentioned earlier, just to complete the thought of CAR T, is that when it was first approved, it was approved for patients that had had at least 4 lines of prior therapy. But as of last month, as I mentioned in April, the FDA now has allowed us to introduce it as soon as after 1 line of therapy for Carvykti and 2 lines of therapy for Abecma. Now, I see that there's already a question coming in: is CAR T going to replace transplant? And that's a complicated question, and it's a great question. The short answer is you are the champ until someone knocks you out, as it were. And right now, stem cell transplant is still the champ, as Dr. Wiesel shared with us. It still has a role. It still does really well. We are doing clinical trials to see if one is better than the other. I'm also very much of the mind, when we have a disease that we haven't cured yet, I don't want to dispense with options. I want as many choices in the toolbox as possible. But yes, we are very likely going to be moving CAR T into the earlier space, just like it's moved into early relapse. We're now doing the clinical trials in frontline. Well, what are these bispecific or even trispecific antibodies? Again, let me try and simplify it. So in CAR T cell therapy, I took T cells out of a patient, I trained them to recognize myeloma, and I infused them back in the patient. Bispecific antibodies are a version of that, but a simpler way, where I give a patient a drug that is called bispecific because it's bi, or it has 2 arms to it. One arm hooks onto the myeloma cell, kind of like the CAR Ts. The 2 of these bispecific antibodies hook onto this tumor cell by virtue of what's called that BCMA target that we described, but B-cell maturation antigen. There's also a different target, and I'll show that in a moment, with the drug talquetamab or Talvey. But interestingly, the second arm reaches out to find a local T cell. So instead of taking the T cell out of the body, manufacturing, and going through that several-week process, right off the shelf, I give this drug directly to a patient, and it basically is a matchmaker, as it were, and it brings together the T cell and the cancer cell and activates that T cell to destroy the myeloma in real time. This is a beautiful example of this concept I shared earlier of immunotherapy, of engaging your own immune system to destroy the multiple myeloma. They've been given different names. Sometimes they're called bispecific T cell engagers, but they all have basically the same kind of approach of bringing together this T cell. At least now we focus on T cells. We've been doing a clinical trial with other cells. We do have other cells in the body that can be soldiers, like NK cells or natural killer cells. And we have bispecifics can be different based on their target, as I mentioned. Although these first ones were targeting BCMA, we have 2 other targets, and I'm sorry that they all sound like license plates, but one is called GPRC5D and one is called FCRH5. There's no test at the end here for you have to memorize these, but these are the targets that we're seeking to leverage in what we do. And so the first approved bispecific antibody was Tecvayli or teclistamab, and it basically showed, as you can see here, a little over 63% or 63%. So about 2/3 of patients with very heavily pretreated myeloma had a response. So perhaps not quite at the level of CAR T, but clearly far above the level we've had of our other drugs. When we look at the drugs we use now, selinexor, pomalidomide, daratumumab, isatuximab, carfilzomib, all of these drugs were approved on the basis of a response rate somewhere between 25 and 30% in very heavily pretreated patients. Bispecifics double that. CAR T triples that. So they're both really remarkable approaches. But here is the first one in teclistamab. And I do want to comment that every drug comes with risk. We have similar risks to what we saw with CAR T. The amount of cytokine release syndrome and neurotoxicities are less and are less severe. It's a big difference between getting mild cytokine release syndrome, where someone might have a fever or feel a little bit off, to someone who may need to be in the intensive care unit, and that rarely happens with bispecifics. On the other hand, the risk of infections is arguably even higher than those with CAR T, because unlike CAR T being a one and done treatment, which is one of the favorite things that people have with this treatment, bispecifics are given constantly or continuously. I think we're probably going to be using less aggressive forms of bispecifics, meaning we won't be giving it every week or even every other week forever like we're doing now, but we have to learn more about that as we go through. We do have another BCMA-directed antibody, a bispecific antibody called elranatamab, which again here, look at this, 64% response rate in heavily pretreated patients. And now we have yet a third bispecific antibody called talquetamab or Talve. This is the one that targets a different antigen, GPRC5D, which is good. It goes back to what I said before of trying to come at the myeloma in a different way, having a different mechanism of action. And we're seeing, again, the majority of patients have some degree of cytokine release syndrome, but the vast majority have what we call grade 1 or grade 2, which can generally be managed as an outpatient for most individuals, but we do have to monitor them a little bit more closely. So as I mentioned, the toxicities are not dissimilar to what we see with CAR-T, cytokine release syndrome, neurotoxicities, cytopenias, and then there's some that are specific to the target. So this target, for example, GPRC5D, is a little different. We actually have GPRC5D expressed on some of our skin and hair and nail, and even in our taste buds. And so it can affect people's taste and can affect their hair and skin. And so we're still trying to learn the best way to manage that. Now, we've also learned, as I've mentioned, that people can get very severe infections. And so we try to prevent them by giving them less drug, by giving them other antibiotics or antivirals. And almost universally, when people are treated with a bispecific antibody, do we give them IVIG or intravenous immunoglobulin to replace the immunoglobulin that they're not making as much. So as I mentioned, we've got differences here between CAR-T and bispecifics. They're both extremely effective. It's a bit of a different strategy. It's kind of one and done with the CAR-T, more continuous therapy with bispecifics. They're primarily given in academic centers, but now we're starting to do it a little bit more in the community. And we do see a little bit more CRS and neurotoxicity with CAR-T compared to what we see in our patients with bispecifics. So a couple of final points on here is that these are incredibly effective therapies. They do come with risk, like everything in multiple myeloma. We really believe that there's a great place for both CAR-T and bispecifics. It's not that it's one or the other. Often they can both be used in a patient eventually. We tend to favor giving CAR-T before bispecifics, but that's more of a discussion for another day. But we are there's still so much research going on. I look at the abstracts that are going to be presented next week at our cancer meeting in Chicago, a week later in Madrid, and even the ones we're planning to prepare for our meeting in December. It's almost innumerable the number of new bispecific antibodies and CAR-Ts that are being developed. And so I show this slide yet one more time. I know I showed it once and David showed it once, but I love this slide. I like options. I like choice. It's really remarkable how many choices we have. I'm going to conclude our sort of didactic part before we jump into some questions around this notion of clinical trials. And I'm going to shorten the slides we have here for sake of time, also for simplicity. But the point here is a few, that we wouldn't be where we are if we didn't do clinical trials. And yet there's a lot of sad history around clinical trials, how people were mistreated, people were misinformed. And this has led to very tight now supervision. You should never feel like you're a guinea pig. You don't go to onto a clinical trial just because it may benefit someone else in the future. In general, we want to put people on trials to help them now. And I know I can speak for Kim. I know I can speak for David when I say that we've each had the privilege of putting hundreds, if not thousands of patients on trials over the years that we know have benefited from them. And so it's very critical that there's open, clear communication between you and your healthcare team. And why would you even consider it? Well, often these trials preview what's ultimately going to be approved by the FDA. So there can be access to therapies earlier. It can sometimes say, well, if it doesn't work, I still have the standard of care, and it may delay it. It may give us an opportunity to treat you for longer. Sometimes there are financial benefits to doing so, but that has to be balanced with some of the toxicities, right? There are always risks. And sometimes we try with trials, we don't know all the risks that are involved. But we know that in our research pattern, this is how we do it. We learn about, let's say, these targets on the cell in the lab, and we test it in the lab and in animal studies, but ultimately we have to bring it to patients. And when we bring it to patients, we really have three major phases of clinical trials. The first is called phase 1, where we really focus on safety. Is this drug okay to give patients? Phase 2, we've said, okay, we've demonstrated that it's safe, but really how well does it work in a larger population of patients? And then phase 3 is kind of the gold standard, where we say, okay, let's compare it to the standard treatment in a very large trial, like some of those trials that Dr. Wiesel and I presented, and then we know it really how effective it is. Sadly, there are a lot of patients that don't participate in trials because they're not aware of them. They don't have geographical access to them. There's been historical mistrust within the system. We still have challenges here. We're not pretending that everybody should go on a clinical trial, but we want as much as possible. Just like every treatment, we want access to patients. We want trials to be accessible to patients. And we also want to know the reality of these drugs in every population. 20% of our myeloma patients in this country, like myself, are of African descent. And yet we look at most of our trials and we have about 5% representation from African Americans, and often even lower representation from Hispanic and Latino Americans. So do we really know that these drugs are as safe and as effective? As we do some of these new CAR T and bispecific therapies, we're learning that there are differences between race and ethnicity and the rates of cytokine release syndrome and the efficacies of this agent. So we have this isn't a, I have the privilege of leading the DEI Council at the IMF, and I often say these issues are personal, professional, and political. Let's take the political part out of it and focus on the professional and the personal part, that we want everyone, independent of their geography, their race, their ethnicity, orientation, whatever it may be. We want people to have access to these therapies because we know that these therapies can really benefit our patients. So as you think about clinical trials and you talk to your doctor about it, ask questions. That is so fundamental. It is built into the process. If you're not given an opportunity to ask questions, that's not been presented to you appropriately. And ask them questions like, what testing will I go through? What do we know about these drugs? Can I stay on my other drugs? Do I still see my local doctor? What is my insurance going to cover? Is there additional or less cost for me? All of these kinds of questions become fundamental as we go through. Know that this is done with your consent. You have to give allowance for this to occur, and at any point you can withdraw that consent. So you have the ability and the power to do that. Obviously, we want to discuss it well in advance so that doesn't have to happen, but that goes back to the importance, as I mentioned, of that open, clear, and honest communication. When I think of the trials that are going on in myeloma, it is almost mind-boggling. If you go to clinicaltrials.gov, you're going to find literally thousands of trials ongoing for multiple myeloma. These new CAR Ts, the bispecifics, the cell mods, so many other things that we've already discussed. So lots to digest here. And in our last 12 minutes or so, I think, Robin, we're going to try again to do a little bit of this rapid fire after all these great questions that we've had. And if we can engage Kim and David here, I will try to zip through them with your approval.
Oh, you don't need my approval, and let's just get right to it because I see we're up to 77 questions at this point, Dr. Joe. So take it away.
I've never seen this many questions at a virtual RCW, but let's bring it on. Okay, Kim, here's one for you. I've heard some institutions offer anesthesia with propofol for bone marrow biopsy. How common is this?
So I know that in my setting, we use Versed, we use fentanyl. We're an ambulatory clinic, so you really don't want to give, a lot of medications that have side effects. And I don't know if that's a good question for Dr. McHale and Dr. Veskal is to answer. What do you do in your setting?
David, what do you do?
So we do all our own. And part of that's a financial incentive on our practices part, to be honest with you. But it takes a lot of engineering. We do a lot of bone marrows between all the heme malignancy people, a lot of bone marrows, and we don't have a set up system to use conscious sedation. It's just too cumbersome and difficult to schedule. So we don't do it. When I was in Arkansas, we had and I think Mayo Clinic, which you're going to talk to about in just a second, has a separate whole section that does bone marrows under conscious sedation. In Arkansas, we had a guy named Bone Marrow Bob who did all of our bone marrows. He did bone marrows all day long. And bone marrow Bob, he looked like a mortician, does, different issue. But we just don't do them in our center. And I'm just gonna be honest with you, it's because there's a financial reason for it as well as a logistic reason for it.
Yeah, I think you just see the spectrum. Just you've described perfectly. Some do it. Some radiology will do it. In some places, like at Mayo, when I was at Mayo, we had a nursing team that did it. We didn't quite have Bone Marrow Bob, but we had a nursing team do it. And so it's something to discuss with the team that are caring for you. Another maybe good one for you, Kim. I'm interested in what you think about stimulants like Ritalin for cancer fatigue.
So usually what I try to do is, work on other options like exercising. What is the cause of fatigue? And so, for example, think about medication, sleep hygiene. I talked a lot about that. So I try pretty much everything that I can before I will use Ritalin. Well, lower doses if that's indicated, but I just think the interaction with Ritalin is sometimes difficult. Will we use it? Yes, we will, but we try other modalities first.
Understood. What question was, what are bispecific antibodies? Hopefully I answered that. Here's a question about if we know there's is there an association, David, between the herbicide Roundup and multiple myeloma?
So I'm not sure. I can tell you that our United States government recognizes 3 different causes of associations with myeloma. One is Agent Orange in Vietnam veterans. Second is 9/11 exposures. They have to have a significant amount of exposure. And the third one is soldiers and their families who served in Camp Lejeune in North Carolina between, I think, 58 and 87 or something like that there was an increased risk of getting myeloma and a variety of other malignancies. Those are the only, at least U.S. government recognized cause and effects, or possible cause and effects. I'm not sure about Roundup, benzene, radon, anything else besides that.
I think that's the right way to answer it. I mean, we just don't know. There's likely some kind of connection. We do have some evidence. Firefighters, we know, are at higher risk, obviously, with as you described, 9/11. But it's very hard because there are a lot of people that have had a lot of these exposures that never develop it. It does seem that Roundup is a little bit more connected to lymphoma than myeloma, but again, challenging to know. Here's a question: can Kyprolis cause neurotoxicity? My quick answer to that is it can. Although the rates are much lower, let's say with Kyprolis than it was with Velcade, just like it's lower with Ninlaro than it was with Velcade, it can happen. We've had clear patients where there's clearly that association, and so it's important for us, to look at every patient individually, but in general, it's less likely. Here's a good one for you, David. How careful do I need to be for the 100 days after an autologous stem cell transplant?
So immune systems take months to regenerate to somewhat near normal, but you have to keep in mind, people get worried about transplant and they tell them you got to watch your diet, you can't go out in public, you got to wash your hands. A lot of that stuff is common sense. There's no doubt about that. I personally tell my patients that a month after the transplant that they should do what they want to do. Just be careful. COVID's still out there. Saw a case, which I haven't seen for a few weeks, of influenza. Saw a case today of metapneumovirus. These things are out there, and you're compromised even after your transplant. You're still compromised, which is one of the reasons that we do post-transplant vaccinations, is to build up your immunity, hopefully somewhere near where it was before. But myeloma patients, even in remission, are not quite the same as people that do not have myeloma. And they need to be continuously aware of their environment and exposures. Excellent.
I think I answered in the question 19 about high-risk aggressive disease versus high-risk versus aggressive disease. Here are 2 questions about bones I'll answer quickly. One of the slides showed lytic lesions. How concerning are they? How are they treated? One of the ways that myeloma affects the bone is that it basically This plasma cells themselves can literally eat out the bone, or it also disrupts our usual balance of the way we rebuild all of our bones. And typically we're constantly rebuilding our bones, and myeloma, it causes an imbalance where the breaking up of the bone to then rebuild it, the rebuilding doesn't happen. And so the bone breaks, and it can be develop these lytic or holy areas where the bone has been thinned. They're treated primarily by stopping the myeloma, right? If you reverse the myeloma, the body will try to heal it. It can be accelerated with bone strengthening drugs, of which we have several, including the next question that asks about Zometa. Been on Zometa for 11 years, received quarterly infusions, now losing teeth. Some say it's a long time to use Zometa. What to do if I also have osteoporosis? It's a bit challenging to be very specific in this case. I would have a conversation very carefully, obviously, with your oncologist and with a dentist. The losing teeth is not typical for Zometa. Usually, if it does cause a dental phenomenon called osteonecrosis of the jaw, it's a little bit more dramatic than individually losing teeth. And that's one of the reasons why everyone should be seen by a dentist before being put on this drug. I think we're seeing less of it in general in the clinic than we used to because we're being more cautious, but it is something that we have to watch for. I think we'll take a few more questions, Robin, because I know time's going really quick. I think we answered a little bit about some of these MRD questions, so I think I'm going to skip over them. I know the 25 is an important question. Daratumumab versus isatuximab, or Darzalex versus Sarclisa. I had the privilege of leading the first in human study with isatuximab. I have a lot of experience with this. I would just answer and say the two drugs are very similar, and we're seeing similar outcomes from them. There are some differences right now in the way they're administered. Dara is typically given subcutaneously. ISA is IV, although a sub-Q preparation is being made. Dara is given weekly for 8 weeks, then every other week for 16, then once a month. The ISA is given weekly for 4 weeks, then every other week for the better part of a year before potentially dropping down to once a month. So there are some differences. But what I think is important to state is that they are similar enough that we typically don't just go from one to the other. So if I'm on a daratumumab regimen and my disease wakes up, I shouldn't just immediately go onto an isatuximab regimen or vice versa. We know that that doesn't really, if you will, overcome the resistance of the others. When he's speaking about transplant, is he referring to stem cell transplant? Yes. So 2 drugs as maintenance showed better results. I think Dr. Wiesel covered that very nicely. Do high-risk patients have a 50% decrease in remission compared to standard risk? The number isn't that clear. It's really on a spectrum. And if anything, we're coming to learn in myeloma that maybe instead of dividing it into standard risk, we need to divide it, and high risk, we should divide it into standard risk, high risk, and ultra high risk, because we're starting to find that there's a cadre of patients that have, as someone else is asking here, double hit myeloma or having more than one high-risk cytogenic abnormality. And we're hoping with our IMWG guidelines to clarify that before too long. We're down to the last minute and a half, Robin, so I'm going to turn it to you to wrap us up. I'm sorry that we only got the first 30 out of 78, my goodness, questions. Thank you, everyone, for asking all the questions. Let me tell you that we will try to answer as many of them as possible at these upcoming events that Robin's going to share with you. And I think, again, I'm motivated to do another Ask Dr. Joe Anything session in the very near future.
It sounds like that makes a lot of sense, Dr. Joe and Kim and Dr. Wiesel. Again, this has just been wonderful. I'm sure that it's the tip of the iceberg because myeloma is so vast and you've covered so much. And for me, being in myeloma for 20 years, every single time you attend one of these seminars, you tend, your ears and your brain absorb it and you hear something new and different. So I highly encourage people to attend more than one of these if you can every year to just stay up to date. And a few of these that we have coming up, these are in-person programs. So if you live in the Minnesota area, we've got one in Minneapolis on July 18th and 19th. And then in August, we're going to be in Los Angeles, and those are patient and family seminars, which are 2-day programs. And then another regional community workshop, similar to this, but longer, of course. We certainly can't imagine you sitting any more than the time you just did with us tonight. But the regional community workshop, the next one coming up, will be in Charlotte on June 22nd. And you can find more information out about these on the IMF's website, of course. And as I mentioned earlier, now that we are wrapping up, we'd love for you, if you have another moment now, you will get this pop-up survey feedback that will appear. If you don't have the time right now, we really understand that, but we ask that when you get the email, please take the moment to provide us with your information. We really do use it. Your input matters to us. And once again, thank you to all our sponsors for this evening. These educational programs are essential to our better conversations in myeloma. And thank you to our esteemed panel of myeloma experts that we have the greatest thanks and just gratitude for your time and expertise always. Thank you so much. And thanks to everyone here. Have a lovely evening. We wish you well.